So today, I've been given the task of discussing about looking after clean wounds. So as plastic surgeons, we are quite intimately related to wound care and getting the best possible wound healing with our techniques and understanding of wounds. So I'm going to discuss some of the facts that will be useful for you guys as junior medical officers or the members of the medical team. So first of all, let's see why do you want to do any kind of wound care? So what are the goals of wound care, right? So we can just broadly categorize those things in one thing is, of course, to facilitate hemostasis. So your wound care may help the bleeding to stop. Of course, decrease further tissue loss. When it's a wound, it may be surgical, traumatic, or infective, whatever. So you want to prevent further loss or damage of tissues and get the maximum possible amount of tissue to recover. And of course, promote healing. So you may use techniques to improve the microenvironment and facilitate healing. And of course, to minimize infections sometimes, right? Sometimes your wound care and wound dressings may help to reduce one thing as a barrier to prevent further microorganisms getting in. And at the same time, sometimes you will be able to locally control the infective load. And of course, you can say to minimize scarring also, because the dressings per se, there are some dressings per se help in better scarring. But generally, if you do all of these properly, you get primary healing in whatever the possible occasions as early as possible without complications. You are definitely looking at a better scars at the end. So that's also a kind of a secondary benefit of proper wound care, right? So now we are talking about clean wounds in this part. So what are the clean wounds? So okay, now we are many, especially considering the surgical practice, so mainly looking at sutured surgical wounds. Those are the biggest category of clean wounds, right? So any clean sutured wounds again can be categorized as clean wounds. But there's more to that. There are many other clean wounds. For example, clean abrasions. They are clean wounds. New burns, which are not contaminated. So they are clean wounds. And of course, the skin graft donor sites, they are quite like abrasions. But they are, because when we are talking about clean wounds, there's a special category, they can be really sterile wounds or just clean wounds. So I'll come to that, because sterile wounds, we can have a very specific course of action or kind of a management protocol. And of course, there are some other clean wounds as well, like, for example, a debrided traumatic wound. So it can be a quite clean wound, maybe even sterile sometimes. And of course, some healing wounds like pressure ulcers, which are not really infected. So they also can be clean wounds. So some of the principles can be applied to such situations as well. But we are mostly looking at kind of a surgical wounds in this lecture. Now, let's look at a sutured wound. There's a suture line, maybe surgical, maybe post-op, maybe just a laceration, which is debrided and sutured. So now, they can be managed with a dressing or without a dressing. In most instances, they will be dressed in some way or the other. But it's possible to manage them open as well. So I'm just discussing these facts. So I haven't prepared any slides. So yeah, just let's have this as a discussion. You can ask any questions, right? Now, I wanted to mention about like now suture line. Now, where can we manage these wounds openly, right? So now from your wound healing modules, you know, properly repaired wound, a sutured wound, the epithelial continuity will be attained within about 24 to 48 hours, depending on where it is. So basically, by 48 hours, they are relatively watertight. So it's not a big problem. You can manage them openly. So generally, we can use open management, especially in the facial wounds, facial lacerations. So because it's a exposed area, it's sometimes difficult to keep a dressing on the face. So it's a very practical solution to manage, and it's a clean area, an easy to clean area. So yeah, so it's very commonly used in the face, and of course in the perineum. You know, it gets contaminated frequently, so it needs cleaning frequently. So it's almost impossible to have a dressing on. So wherever, when you manage a clean wound openly, what you can do is you can wash the area frequently, maybe 2 to 3 times a day with clean soapy water. You don't have to disturb too much, but it's important not to put the chemicals like soap bar straight on the wound, because there can be some chemical irritation. So just dilute soapy water, clean it 2-3 times a day, pat it dry, and apply some maybe antibiotic ointment, or just simple moisturizing cream will also be enough. And it's important to maintain the hygiene of the area, like to have clean clothes, change them frequently. Like if it is a face, keep the very clean pillowcases, things like that. And of course, then going back to dressings. Now, clean sutured wounds don't need a lot of dressings. Sometimes you just put a dry dressing. Most of the time it's dry dressing because the microenvironment is maintained by this little clot at the edge. So you don't have to facilitate from outside too much. But then to keep it undisturbed, you put a dry dressing, sometimes just tapes like Steri-Strips or sterile Mefix. And sometimes we do like with hi-fi closure techniques like tissue glue and like film dressings and those things. Now, rarely there may be a bit of oozing, and you think you may need a non-adhesive dressing like a Vaseline gauze. The surgeon will decide on that, and sometimes, rare instances, they might put more absorbent dressing if you anticipate a bit of oozing or some kind of a serous discharge. Now going back to dressings or wound care, if you think if you go back to the initial goals we talked about, now there are certain things that you can use. Now, for example, we talked about hemostasis. So what are the measures of wound care that you can use to achieve hemostasis? So the first principle is not to disturb small clots in the surface. So if you, for example, if you put a dry gauze on a oozing like abrasion or something, each time you remove it, the clots will be dislodged and the bleeding will continue. Whereas, so you may have to put a non-adhesive dressing like a Vaseline gauze or silicone mesh or something like that. Using moist gauze if needed will be helpful rather than using dry ones. But at the same time, like products like adrenaline saline is a very useful agent. Sometimes you can make a little cocktail with adrenaline, saline, and topical tranexamic acid as well, right? But then, yeah, that's how we facilitate hemostasis with wound care, right? So, and like promote healing, sometimes like there are some better commercially available products, like hydrocolloid gel, sometimes calcium alginate. Of course, calcium alginate help with hemostasis also, right? Those things are there. And of course, the different type of barrier dressings are there, like there are some film dressings which allows breathing or air exchange, but work as barriers for microbial movements. Yeah. So, and you may use a antibiotic incorporated dressing or antibiotic application in order to avoid infection or minimize infections. Yeah. So now, then, of course, we were talking about sutured wounds, no? So then, when they are cutaneous sutures, we need to take them out. So you hope you already have a certain idea of when to remove sutures. But then let's try to understand, why do we need to remove sutures? Yeah, anything which has served its purpose, there's no point keeping them any further, especially because they can cause some other adverse effects or like side effects. Because you have seen, like, now the point of suture is a constriction point. So it cuts off blood supply at the point of suture. So if you leave it for too long, that can cause a scarring in that area. You see these, some of the suture lines, they have cross hatchings, what we call them cross hatchings. They look like centipedes, no? Like pattaya-like appearance. So to basically, we try to avoid that. We have to avoid that. So we can generally we use sutures, remove sutures. And why it is different in different places? Yeah, the healing or the vascularity of different parts of the body are different. So face has a very good blood supply and healing is very good, and it heals very quickly. And the other thing is the tension across the suture line is also a factor affecting that. So in any area, suture line on one direction may take longer than the other direction to heal. So in general, in face, we remove sutures in about 5 days or even earlier that. In the neck, 5 to 7 days. Scalp in about 10 days. Upper limb, trunk, 10 to 14 days. And lower limb, probably 14 days or more than that. But then there may be some special situations. So generally keep this kind of a guideline basically, but adhere to your unit guideline. So your consultants may use a specific closure method, which may allow removal of sutures earlier, or sometimes they may have special concerns. They may ask to leave the sutures for long. So coming back to the same thing, so these problems occur in like interrupted sutures, basically, with any suture going across the surface of the skin. So in that sense, the subcuticular suture, like removable proline subcuticular suture, doesn't cause much of a problem even if you leave it a bit longer. So sometimes in that case, you can take the decision accordingly. And then, so after removing sutures, what do you have to do? So we see a lot of, most of the time, the patients don't get any information following removal of sutures. So generally then, normally when you remove the sutures, the skin is adequately healed. So most of the time you don't need any further dressings. But for safety, sometimes you might decide to put a dry dressing on, or maybe just simple tapes on for another week or so. But then you have to start on moisturizing the scar and some basic scar therapy by the means of moisturizing and gentle massaging. So, because that will facilitate quicker healing and quicker recovery. The pain will go down sooner and the scars will also be better. But if it's a concerned area, cosmetically concerned area where you think better scar therapy is needed, so you get proper advice regarding that. So generally, I thought, so that will be the basic things I wanted to discuss. So let me know if there are any concerns, any queries you want to clarify. Okay, there are a few questions. Let me see. Now, there's a question about the pressure ulcers with like slough and things. So just so it's not really relevant, directly relevant to this topic. So I think there are some topics, discussions around those factors. So I'm not going to do anything much about that. And of course, there's another question about hydrocolloid dressings. How many days you can keep it. Now, so it depends again. So it's a good question, because hydrocolloid is a nice, very useful dressing, but sometimes you misuse it. Yeah, because as I said, so it depends on for what purpose you have used it. So remember, I told about the skin graft donor site. So that's a sterile, surgically created skin abrasion. So there we will put a hydrocolloid dressing under sterile condition and leave it undisturbed until it's healed. So basically it may be 2 weeks. So it heals by its own, and it'll peel off once the epithelialization is complete, because it acts as a good barrier to infections as well. On the other hand, if you use it on a different situation, there is some colonization, concerns of colonization or something, so it should be removed in 3 to 5 days. So it's situational. So but that's the fundamental. If you think it's a clean and almost sterile wound, you can leave it for a longer period, because that way you don't disturb the wound much and let the natural healing process occur without mechanical disturbances. So it applies to whenever we do take split thickness skin graft, even without those things, even if you dress it with Western gauze and conventionally, still we leave it for generally about 11 days, 14 days until it's completely healed. Only very rarely we have to disturb it. Yeah, about the facial sutures, yes, most of the facial sutures will come out in 5 days, right? If you have put some deep dermal kind of supportive sutures, you can even take it on day 4 also. But if it is under tension, like against tension lines, then sometimes the surgeon will decide to leave it for 7 days or so. Yeah, it's about moisturizing the wound. Now, if it was an open wound, the patient may already have some antibiotic ointment with them, like you use things like mupirocin or gentamicin, chloramphenicol, those things. So they can use the same ointment for another week also for initial moisturization. But then you can use a very basic moisturizing cream without much additives. But then if they can afford, they can go for bio oil or any other moisturizing oil, or even better, if you can use a silicone-based product. right? Silicon gel including the integrated product. Yeah, scar therapy, I just mentioned the baseline scar therapy. We just start with silicon gel application and gentle massaging 2 to 3 times a day. But then you can use pressure devices, taping, and those things. It will be too comprehensive if I try to, too complicated if I try to give you a comprehensive account on scar therapy here. But keep it as the baseline, right? So about diabetic wound care, there is a question, but I would leave it for whoever's doing the topic because I shouldn't be giving mixed messages to you guys. Yeah, again, a question on oozing. I just oozing in the sense we already discussed about bleeding, like abrasion bleeding. How can you stop? You basically use adrenaline saline, non-adhesive dressings, and of course, if needed, you can use topical tranexamic acid as well in combination with adrenaline saline. But then there are the dressings such as Surgisil, Caltostat, calcium alginate. There are some ready-made products as well you can use. All right. Okay then, guys. So I think we have come to the end of the allocated time. Yeah. So good luck again then. And thank you very much for your attention.
Right. Thank you very much, sir, for that practical interactive lecture. That was Dr. Aranjit Amarasinghe, consultant plastic surgeon at LRH Colombo. So thank you, sir, once again. So next up is skin care for acute wounds, done by Dr. Sashanka Ratnayaka, consultant surgeon. So sir is logged in. So over to you, sir.
Okay. Good morning, everyone. Share the screen. Yeah, okay. So my topic is actually, can you hear me? Can you guys hear me?
Yeah.
So basically, this I have to cover this topic in half an hour, but I think it's a very big topic to cover. So I'll try my best. So congratulations for our interns. We are starting a new journey today, in future. So you got to listen to a couple of plastic surgeons, and I must warn you, after listening this lecture, sometimes you may listen to some of the things you may have not heard before, and sometimes there can be contradictions with the general surgical bosses you are going to work with. So you have to be a bit, sometimes you have to be a bit diplomatic in that. So it's our duty to teach you the correct things. So therefore, I will proceed. So basically, the objectives of this lecture is to understand the basic principles of achieving skin cover in acute wounds, and you should know how to manipulate the wound healing process so that we can discharge the patients early from hospital care, and just a general idea about the reconstructive options in acute wounds. And there is some malpractice happening in our system, and just an overview of that. So what are the causes for acute wounds? Basically, sharp injuries with crush and shearing and also blunt injuries. Some ballistic injuries can happen also occasionally, and the burns. The types of acute wounds, incised wounds, abrasions, lacerations, declaving injuries, avulsions, and burn wounds. I think burn wounds it's been already covered, but I will try to touch some of the areas. So first one is the incised wound. So you have a clean cut, maybe a sharp knife or sword, or you commonly get in the cervical boards. So there is skin and subcutaneous tissue breach with a sharp cut, and the cut may be having variable depth. So you have to, depending on the anatomical region of the body, say if it is a hand or forearm or leg or wherever, you need to have an understanding about the underlying structural damage. So you need to recap your anatomy knowledge. You can't say that you have done anatomy long ago. You should have some idea on what structures may be damaged, and you should be aware of how to examine the patient's damaged structures. So if you have forgotten that, it's better to refer the examination of the hand, and it's been probably done in this lecture series. Examination of the limbs, nerve examination, neurological examination, those things you need to recap. And it's very important document. It's not happening among most of the intern house officers. So it's very important to document whatever you examine, because of course there are no legal issues in our system at the moment, but can be in the future. And when there's an incised wound or sharp cut, it's very important to wash and close quickly. Sometimes the structures damaged underneath you may not be able to repair. Say, for example, nerve injury or sometimes a tendon injury in some of the difficult areas of the hands and all that. You may not be able to repair, but you need to close it quickly. Otherwise, wound will get colonized and you can get infected. So you need to document it, skin closure, and then refer to probably plastic surgery unit, right? So when we say about suturing of the wounds, closing the skin, it has to be a simple suture. We don't recommend vertical matrices. It is being used in most of the general surgical units. It causes more trauma, right? So, and when you do a proper suturing, you don't have to have big dressings. I think it's been already addressed in the previous lecture. Generally, after 3 days, you don't have to have a dressing or a properly sutured wound. And especially on the face, you don't have to dress the face. And because if you dress the face, sometimes the the sick patients coming from all the orifices of the nose, mouth, and the eyes can get contaminated, and that can be a culture media for the organisms. So we need to tell the patient, so look, we have sutured your wound and you need to get the suture removed on a particular day. So that has been already discussed. How many days you need to know depending on the anatomical area. So suturing of the skin, you need to go for an appropriate size suture, right? So it's very important. If it is the face, it's probably 60, and if it is hand, 50, upper limb we recommend 40, lower limb it is 30. So why we recommend small sutures, the appropriate size sutures is the needle size. So if you use a very big needle, very stout needle, it's going to cause skin damage. So that you need to understand at the beginning of your journey. So something like that, you just suture and you don't have to cover. And don't do this. So this is not acceptable. Facial dressings is not acceptable. So the next one is abrasions. So in abrasions, of course, there is variable loss of skin. So we know the skin is composed of epidermis and dermis, and epidermis has got 5 layers. So it can be variable depth, like a burn. So if it is only epidermal injury, usually the abrasion is there's only the loss of epidermis. We say kuduhamera. So those wounds are going to heal spontaneously from the dermal appendages. The basal cell layers are going to regenerate, and it's going to heal by regeneration. operation without scarring, provided you remove all the dirt, sand, mud, or sometimes they can be tar with a nice scrub. So it has to be done under anesthesia. It could be local anesthesia, or could be general anesthesia. You need to do a good scrub and decontamination of the wound in operation, and allow it to heal and manage this as a burn wound. And facial abrasions, you need to manage them open. It's better to manage them open because putting dressings can be a problem. We have already discussed that. And it's going to be very painful, so you need to provide adequate pain relief. And mind you, the wounds are going to heal from bottom to top. It's not going to heal from the edge of the wound, like in secondary intention heal. And if you want to prevent scarring, you need to do a first wound scrubbing is the very most important thing, something like that. And then comes the lacerations. Lacerations happens due to less sharp injuries, and it can be again depending on the injury. There can be variable depth of underlying structural damage. So again, you need to examine and document. And then after that, sometimes you may be able to repair the underlying structural damage. If you cannot repair something like nerve injury or a tendon injury, then you need to wash and make it as an incised wound by debriding 1 millimeter. It's very important to do that. Sometimes when we have, especially in the scalp, you might get to suture in the scalp. You need to remove 1 millimeter of the scalp laceration. Otherwise, we will not remove the contamination of the skin edge. And also the crushed edge. It is not going to heal properly. And then again, when you have converted into an incised wound with debridement of 1 millimeter of skin, then you can close it with appropriate size suture with simple sutures. And again, a small decent dressing. And you don't have to dress after 3 days. You don't have to arrange every other dressing, say in OPD. Sometimes it happens. Don't do that. It's not necessary. It's an unnecessary workload for the healthcare system. And also, you give a suturing order. Best thing is when you are done about suturing, you ask the patient to go home and wash. Probably, even you don't have to wait for 3 days. After 24 hours, you can wash and apply a skin ointment, maybe a better ointment, or maybe water, something like that. So these are dog bites. So dog bites can be sutured, right? Provided you debride 1 millimeter and remove the contamination and colonization of the skin, and then you do the nice suturing. You don't have to have dressing over the face. Then comes the degloving injury. So this is very important to understand because this is one of the wounds mostly mismanaged. And we see when there is degloving injury, there's a variable amount of skin loss from the wound, and skin cannot be approximated. And so you don't try to somehow or the other approximate skin wound with using big sutures. So it's not acceptable. If it is simple and straightforward skin only lost, so sometimes the skin is lost, but underlying adipose tissue and underlying muscles are intact, and it's very easy then to manage. So you go for skin grafting on day 1. So if it is contaminated, you can delay it for a couple of days, depending on the situation, but you don't wait for granulation tissue. So here comes the mostly, sometimes it can be contradictory with your bosses, but that is the way how to manage it properly. So best thing is to go for primary skin grafting so that you can prevent skin graft infections and bone infections, and probably you can discharge the patient very early from the home. And if it is a very big skin loss, you need to seek for help from the plastic surgical unit. But if it is not, if it is a small skin loss, you can, the general surgical house also probably can learn how to do skin grafting, can do it. something like that. Of course, you have to refer to plastic surgery. So this one had a harvesting machine injury, scalp got avulsed. Luckily, the periosteum is intact. So it was grafted on day 1, same day, and it is healed in day, fully healed by day 10. So something like that, the articulation of the upper limb with a train accident. So skin grafting was done day 1, right? And it is healed by day 7, day 10. Patient can go home after skin grafting in the patient's pain and all that coming in a couple of days. So it's going to be very good for the patients. Sometimes you get declaving injuries where there is more than skin and subcutaneous tissue loss. So the bone and joints sometimes get exposed, right? So sometimes the fracture is exposed, and we have a Castillo and some classification for that. If you are not, if you cannot remember, you need to read that again, Castillo and some classification. And so sometimes when the bone and joints exposed, they need a soft tissue cover, but we cannot provide the soft tissue cover or a flap on the first day. So we need to temporize the wound. So what do you mean by temporize wound? You prevent colonization of the fracture or exposed joint or exposed bone with organisms. So it can be done simply with the sometimes with the film dressing, right? So there are film dressings available. You can use them if there is no access to negative pressure wound therapy, but negative pressure wound therapy with the ideal or wet dressings would be the ideal. And you need to take photographs of the debrided wound, and then need to discuss with the regional plastic surgical team about the future plan of what you're going to do. And so VAC is not for a substitute for the soft tissue cover. You don't keep on applying VAC over and over again. You need to discuss the plastic surgical team. So something like that. So you temporize the wound back and then refer the plastic surgery team for soft tissue cover. Then comes the burn wounds. Burn wounds, I think, has already covered, but I will always again recap. You need to understand, depending on the depth of the burn, if it is superficial partial thickness, if you manage to keep it as in the level of superficial partial thickness without infection and with proper resuscitation in the first 24 to 48 hours, then it will heal by 10 to 14 days. But if it is deep partial thickness, it may take about 21 days to heal. But if a wound is not healing by 21 days, you don't keep on dressing for 6 months and then allow it to heal one fine day. You don't do that now. You need to skin graft that on day 20, after day 21. So you can see the first on left side upper one is the superficial partial thickness, and you can see the deep partial thickness and full thickness with the whitish, right? So if you have a minor burn with full thickness burn, you don't wait, till day 21. You go for skin graft probably on day 1 or day 2, right? So immediately cutting initial excision and skin grafting. If you are not aware of it, you need to seek for plastic surgical therapy. So if you allow a burn wound to heal after 21 days with scarring, these may be the results, and don't help these things happen to the patients in the future. So it's going to be sometimes your responsibility. Skin graft care. So when you do a skin graft, of course, you need to do inspection of the recipient. So if it is a sheet, if it is a mesh graft, of course, you don't have to see on day 1. But if it is a sheet graft, you have to see the skin graft on day 1, so exclude hematoma under the skin. And then we see the wound in day 7, and sometimes day 10, you go for skin staples removed. And if it is a donor site, it was discussed before, you don't disturb it. You have to have a bulky dressing and just leave it for 14 days, sometimes 21 days, and allow it to heal and fall off. Sometimes patients may complain of smell and all that. It's usually the body smell or sometimes the exudate smell. But if you really want to change, you can change the outer dressing and reinforce the dressing rather than removing the whole dressing and redoing the dressing. So skin graft care, I'm not going to discuss, but this is going to should be a separate topic. It starts after day 14, pressure garments and skin graft moisturization, scar management, and all that. So it's probably beyond you. So if it is a big skin graft, of course, you can send the patient for follow-up by the plastic surgery team. So in conclusion, we need to understand appropriate wound care should be appropriate wound care would prevent acute wound going to chronic phase, and appropriate wound management would expedite the healing process. So you don't wait till granulation tissue comes and skin graft primarily, so that will expedite the healing. Wound care does not mean using modern commercially available wound dressings in the patients. So it's appropriate decision making is very important in acute wound care, and you need to understand the principles and manage the acute wounds appropriately. So thank you for your attention. So questions are welcome. Some questions coming. So there is a length beyond which is laceration needs.
We have about 10 minutes more, sir.
Yeah. So we can ask questions. So what is this question? There's a length beyond which the laceration needs suturation. I don't get the question actually. So if there is a big gap, in the laceration, if you can't approximate the wound, maybe the question, if there's a big gap, that means there is some skin loss in the skin, so that you cannot approximate that laceration. So you don't try to approximate with your strength or big sutures. You will have to go for, so there is some element of degloving in that laceration, which is appearing as a laceration. So you will have to go for skin graft. Any other questions? Okay, shall we wind up? There are no questions. We can wind up.
Okay, sir. So,
what are the antibiotics that can be used? Yeah, I mean, depending on the injury, depending on the contamination, need to select the antibiotics. So generally, after lacerations, moderate accidents, I prefer to use clindamycin. But we see, the poem object lab is not effective most of the time. But if the wound is very clean, of course, you don't have to use clindamycin, probably poem object lab, or maybe cefalexin would be sufficient. So it is kind of a clinical decision. So you can't give a blanket answer for that. Okay then, right. Thank you guys. Right. And good luck.
Right. Thank you, sir. That was Dr. Sasanka Ratnayak, consultant plastic surgeon at National Hospital, Kandy, for that informative lecture. So next up is skin cover for chronic wounds done by Dr. Yasas Abevikrama. I think sir should be logging in a few minutes, so stay joined.
Dr. Yasas will be joining in 5 minutes.
Okay, right. So a few updates. So we will be sharing a link, and the link will lead you to a common MCQ and e-certificate. That e-certificate, like, there are about 300 questions from all specialties. So those who follow the sessions and will be able to answer those questions, MCQs, and in the certificate it will highlight how many out of 100, out of 300, how many you got right. So it's important for you all to follow these lecture series. Tell your friends as well. So these certificates include all the college president's signature, director general's signature as well. It's a valid certificate. So it's a compulsory certificate for internship enrollments. So make sure that you follow the sessions, listen thoroughly, and ask questions, update your knowledge. That's our motive for you all. So that's the message. So we will share attendance link during the course of this session. All right. So there are about 293 and plus about 53 from the live broadcasting, only few participants. So the link will be activated for few minutes. Once the 320 is is filled, we will close the link for registration. Right. We will share some internship booklets rather to the chat box, so you all can download them, and very important as a guidance for internships. So we will share that booklet in the chat box also. So please stay joined.
Katayan, Zoom.
Good morning. I thank College of Surgeons for the opportunity to share this information with you. This, I think, will be very useful when you start your internship as a young clinicians and to develop your career. Some of the things that we discuss are in the book, some of them are not. So we are going to discuss the cover of the chronic wound. So we have mentioned skin cover.
Sir, sorry to interrupt you, sir. Can we get the computer close to you? Bit echoing.
So, can you hear me?
Now better, sir. Yes, thank you.
Okay. So we are going to discuss on these topics. We are going to discuss the basic concepts of wound healing and the time concept, which is how we get a wound bed, prepare a wound bed to accept reconstruction that may be healing by its own secondary intention, or to add a reconstructive procedure like a skin graft or a flap. Then we are going to discuss a protocol like ATLS, how we plastic surgeons think about reconstructing a soft tissue defect. Then we'll show some applications. So wound is a defect in an organ or tissue. We call a wound which has occurred within 3 to 4 weeks an acute wound. But it has, if it has gone into chronicity, a wound which is persisting more than 4 to 6 weeks by definition is a chronic wound. But then, of course, we have to assess the parameters, and this wound is going to heal after 4 weeks plus 1 day. That's an acute wound for me, as far as practicalities are concerned. And so these chronic wounds have delayed healing and non-healing wounds in that category. And wound healing occurs by repair or reconstitution of a defect of the organ or tissue, usually the skin. So ideally is tissue regeneration. Then there are no differences, no scars, no deformities, no differences in consistency, texture, or quality. As versus scar formation, which is by forming a scar, then the scar is going to contract, which may have some deformities, but still may cover the wound. So in acute inflammation, we know the sequelae are resolution, suppuration, liquefaction, fibrosis, or chronicity. So in the resolution, what happens is there are 3 phases: inflammatory phase, proliferative phase, and the remodeling phase. So this is the inflammatory phase lasting about 4 days with the platelet plug and everything coming. And then the proliferative phase, all things are collected for repair. And the wound is, if it is healing with secondary intention, fills with granulation tissue, new vascular vessels are forming, and the scar above is replaced by epithelializing edges. Then once the scar is formed, Then that remodels, it softens up and comes into a mature state where the minimal effects of the scar remains. That's the ideal situation. But most of the time, this organized pathway does not occur very smoothly. So healing is a wound cycle. So on the left side, you see a healing wound injury. Then it passes all three phases and finishes in resolution. But what happens if there's a challenge? The challenges may be nutritional, infective, external forces, micronutrients, specific micronutrients, global malnutrition, recurrent breakdown, multiple diseases, iatrogenic, like steroid treatment. So those many challenges can inhibit your wound healing cycle at different places. So when it is challenged in the inflammatory phase, then your wound goes into chronicity. It may suppurate. In the proliferative phase, again, the wound will not heal. It will be a chronic wound. It will start granulating and breaking down. If it is challenged in the remodeling phase, then you get all the bad scars, hypertrophy scars, keloids, repeatedly breaking down scars. So as clinicians, we have to identify all these problems in different phases and resolve them so the patient's wound can resolve and have a soft and pliable scar if it is by secondary intention, or if the patient cannot get a good result, use other interventions like skin grafts, skin cover flaps to help the patient to cover the wound. So just my classification, acute wounds needs good closure as discussed. Then potential problem wounds like it may be the injury, crush injuries, injuries with contamination, or the patient who's poor nutrition, medical problems on treatment. So these patients have potentially problem wounds. And those chronic wounds, what we have to do is get them into the wound healing pathway, correcting the challenges. The challenges are in the general care and the wound bed. General care is you improve nutrition, control diabetes, medication, ambulate the patient, offload any pressures, like pressure areas. Then the wound bed preparation is a special discussion. And then we have to cover the wound, and we'll discuss the concepts on that. And some wounds, like in the patients who are not going to recover, or patients who are not fit for these procedures, conservative management is also an option. So here we are discussing a very important concept that you have to go to the internet and follow and read about. It's the time concept. Is about how to get a wound bed to improve so that it will either heal by secondary intention or be fit for other reconstructive modalities like skin graft or flaps by improving the wound bed quality. And time concept has two parts. That's a wound bed preparation. Other one is general care of the patient, as I said earlier. So time is T is for tissue, I is for infection, M is for moisture balance, and E for edges. This concept has been developing from 2003, and 2003 there's a guideline, and then 2012 there had been a guideline. So it had been further developed now, so that in this central picture you see the wound bed preparation, the tissue, infection, moisture balance, and epithelial edges. They surrounding that, there's another part, the light blue ones, we discuss surrounding skin, cost and benefit issues, and holistic assessment and care. Then around that, the concept also involves patient environment, improving the patient environment, then improving therapeutic services environment, that is the available facilities and training for the healers. Then the healing environment is the wound bed. So this is a whole concept that you have to go further into and do some referring up in the internet, which is abundant materials are available. And this is how you use the time concept to heal the tissue, debride, control infection, balance moisture by allowing not to desiccate or be too waterlogged, then organize the cover either by epithelializing edges or organizing reconstruction. So another patient whom we have used the time concept, that is tissue, infection, moisture balance, and epithelialization. That's tissue. In the first picture you see necrotic wound, we have debrided it. Then that is an infected wound. So we have used rotational antiseptics to cover the infection. And once the wound is sufficiently infection control, we have gone for negative pressure suction, which will help with the epithelialization and making the wound smaller, and then cover the wound. So this is the 2003 document about the time, and this is the 2012 document about the time concept. But then this looks too complex. So I summarize them into 4 slides. Tissue. When there's necrotic or non-viable tissue, we have to debride. We can use surgical means or non-surgical means, like surgical, like sharp surgical debridement, hydrosurgery, or non-surgical means like autolytic, enzymatic, larval debridements. So the target is to have a viable wound bed, clean wound bed. So that is devoid or having less necrotic non-viable tissue. Second is infection. Infection in a chronic wound is highest challenge is to identify that there's an infection. Acute inflammation, you know, color dolorobo, tumor, and loss of function. Now you know there's an infection. But in chronic wounds, sometimes it's challenging to identify whether there's an infection, especially in the elderly age group. So some of the ways are that the recurrent wound breakdown, chronic pain, malodor, buff colored, purple colored wound base, recurrently breaking down wounds, collection of pus. So these may be indications of chronic infection. So identifying infection and then removing any infected foci, maybe dead bone, foreign bodies, contaminated material, past sutures or implants. So removing them, then we can use topical or systemic antimicrobials. If there's infection with cellulitis, you can use antibiotic systemic. Topical antimicrobials sometimes are practical. We can use anti-inflammatories and medication which can attack biofilm to break the biofilm. Can be used. Mechanical devices like physical upgrading devices or chemical material can be used. So the common chemical materials that we use to attack biofilm can be cadmium iodine dressings, silver dressings, and polyhexanide dressings, which are all available in Sri Lanka. So the objective is not getting rid of bacteria, it's bacterial balance. Reduce the bacterial load and inflammation so that the body can handle it. And for infection control, I use rotational antiseptics. I use 0.5% to 1% acetic acid, then hypertonic saline and 10% povidone iodine in rotation. I don't personally use Milton solution, but that can be used as one of the rotations. And also in resistant cases, we can use silver sulfadazine as one of the rotations. And then MRSA is another concern. MRSA is not a more virulent infection, but is resistance to our standard treatment regimes. So if there's a patient with identified MRSA contamination, then we can use chlorhexidine bars 5 days, mifepristone ointment twice a day to nose, stop the treatment for 2 days and send a culture ABST. That is the MRSA decolonization protocol. But if a wound is infected by MRSA, then debridement, and we can treat with antimicrobials like vancomycin, which have to be used with care, and go for chlorhexidine treatments and a debridement as necessary. Then coming to moisture, TIME time, moisture, the best environment for a wound to heal is a moist, dry environment. Now that is contradictory, like it's like telling, I like a black and white girl to marry. So we want a moist and dry environment. What does it mean? It does mean the wound can't be desiccated. And also the wound can't be waterlogged. So it will be macerated. So in between situations, the best for wound healing. So it has to be moist and also devoid of extra moist, no desiccation and no extra moisture. So how do you do this? If the wound is highly exudating, then we can use absorbent material like lot of gauze, foam dressings. If a wound is getting desiccated, we can use moisture retaining dressings, film dressings, then various gel dressings, hydrocolloid dressings, something which applies both for correct both challenges in moisture balance. It's a negative pressure suction. It retains the moisture as well as absorbing any extra moisture. So it's a good adjunct to our wound management. So objective is to have a moisture balance. And E is wound edges or an epithelialization. Ideally allow epithelialization or get the wound bed prepared for a reconstructive method. So how you do this is by debriding. Maybe use skin grafts or flaps, use promoting agents, and even sometimes we have used platelet-rich plasma to improve wound healing. If the wound is ischemic, then you have to correct the cause. So getting your vascular colleagues involved to improve the vasculature. And therapies like negative pressure suction, ultrasound treatments, laser treatments, and hyperbaric oxygen, which will increase the dissolved portion of oxygen in the blood, the serum, may help for improving epithelialization. So when you do that, now we have a viable wound bed which is ready for either healing with secondary intention or to accept a reconstructive procedure. So what are the concepts of reconstruction when we come to healing a chronic wound? So we call it the reconstructive ladder. So the lowest rung is doing nothing, allowing secondary intention healing with supervised neglect. Next complexity is there's a wound, you close it by primary intention, that is suturing. Sometimes wounds are contaminated, so you can't close them primarily. So delayed primary closure is the next rung. This goes up in complexity. Next level is skin grafts. Then you can use tissue expanders to expand local tissues to cover wounds. Then local tissue transfers. Tissue transfers are flaps. Flaps are tissues which are brought to any other place with continued its own blood supply. Then free tissue transfers or free flaps are tissues which are brought to places and anastomosed to the local blood supply. So though we call it a ladder, in a ladder you go by step. But now we talk about the reconstructive escalator because we don't want to go from the lowest rung to most complex one by one. As clinicians, we see and decide what is the best for this patient. So we go for the simplest and practicable option. So simplest may be a skin graft in a patient. So we are not doing the secondary intention, primary intention, or delayed primary closure. So out of these options, we select the simplest and practical option. And the option has to be a biomechanically sound option to avoid recurrent breakdown. So on a pressure ulcer, you will do a local flap rather than a skin graft, because doing a skin graft will also cover the wound, but it is liable for recurrent breakdowns. So this is how we do it. You identify the patient, and whether you are going for reconstruction, if there's ischemia, then definitely we have to go for revascularization before the reconstruction, and then decide where to intervene. And during debridement, especially in the feet, we have to identify avoiding the foot blood supply and avoid damage to critical blood supply, because doing massive wound debridements without knowing the anatomy can lead to making the ischemia worse. And then, as discussed, then we are going to discuss the reconstructive options. And patient has to be prepared, optimized, and educated about the procedures. And in the time concept, we are organizing the wound bed preparation and the general care of the patient. Then infection control, which we discussed. Then if it is a wound which is liable for pressure, like on a foot wound, then offloading is very important. And then we have to give realistic expectations to the patient and the sort of timing for wound healing to the patient. And after the wound heals, managing the scar is very important. Otherwise, there can be recurrent scar breakdowns and rehabilitation of the patient. So that's what this diagram talks about. There are patient requirements, there are requirements of the wound, and there are things that we can do. There are things that we can do in a tertiary care hospital and things that we can do in a primary basic setting. Wherever we are, there are things that we can do, and we have to do our best to help the patient in the wound. Few examples of the reconstructive ladder. Now, this is a patient with burns. Wherever necessary, we do skin graft, but some of the areas we can allow healing is secondary in patient and do scar management, like this wound on the shoulders. This is primary closure. There's a wound, and it's a 2-hour-old baby, forceps injury. We have debrided and sutured primarily. And after 6 months, we could not identify which twin had the forehead injury. This is a delayed closure. So this is an abdominal wound dehiscence. Now you can't just pull it and close, but then we can improve the wound bed like time concept and close it little by little. And after about 2 weeks, we got the wound to totally heal. The same concept can be used like in contaminated animal bites, where you can debride the wound and close after 48 hours. Next complexity is full thickness skin grafts. Skin grafts can be of different thickness. The more the dermis, the quality is better. More the dermis, the donor site healing is delayed. When you take a full thickness graft, you have to cover the donor site by closing it with suturing. A split thickness skin graft, you can allow the donor site to heal by itself in about 2 weeks. So this patient, we have done a full thickness skin graft. And here, this wound, we have debrided, used the time concept and improved the wound and done a split thickness skin graft. And this patient was a liver failure patient with hyperproteinemia. Even with that, we have done a mesh skin graft with negative pressure suction, which has given us a 100% graft take. So this negative pressure suction is an adjunct where we can use for improving the outcomes of skin grafts. This is a dermal substitute. In a scarred bed, putting a skin graft, the skin graft can break down recurrently. So you can use a dermal substitute which will act like a new dermis. Then graft on that, which will give more supple and more stable skin, like a full thickness skin graft. When areas are big and the availability of grafts are less, we can use skin expander systems. One thing is doing meshing the graft, like in the previous patient. This is another system which is called meek grafting system to increase the area that can be covered with a small graft. These are tissue expanders. You can, for a wound which you have some time to manage, or you do initial skin graft, then apply tissue expander, get the local tissue to expand, and then use that tissue by removing the bulb inside. You use the inflatable bulb and remove it, and use that extra tissue to cover the wound or the scar. Sometimes amputation is also an option. In here, we have amputated the non-functional middle phalanges and used the tissues as vascularized flaps, fillet flaps, to cover the wounds. Again, this patient after osteoradionecrosis had 6 years of non-healing wounds. So this wound we have to debride totally, and we have moved the latissimus dorsi muscle as a local regional tissue transfer and heal the wound. Sometimes we can use perforated flaps. Without sacrificing the main vessels, we can use skin perforators to cover chronic wounds after debriding using time concept and get good wound cover. Next complexity is free tissue transfers. Free transfers are you debride the wound and bring in a tissue from a distance. I think Dr. Gayan may recognize this patient. And then you can apply skin graft on this, or you can bring a fasciocutaneous free flap also. Whatever reconstruction you do, the long-term management is important, scar management. Now, this patient who had a skin graft, split thickness skin graft to the foot, railway accident, and he had the option of either amputation or skin grafting with lifelong prosthesis. This lifelong patella weight bearing prosthesis which he is using. So what I want you to remember is select the appropriate wound cover and know your reconstructive options. We can use combinations. Even amputations are good treatments. Coming up to the reconstruction, the time concept is very important and is something that you have to go and read about today. And follow-up care, scar management, and rehabilitation is essential. Thank you very much for joining us.
Right. Thank you very much, sir. If we can take a few minutes to answer any questions everyone is having, so you can use the chat box or unmute yourself. At the meantime, next lecture is by Dr. Niluksha Jayavira on head injury.
ඒක රෙකෝඩ් වෙනවා නේද ඔයාලගේ ලෙක්චර්? නෑ. මම මේ හිතන්නේ මොකද මේකේ සමහර ඒවාගේ පබ්ලිෂබල් ෆොටෝස් තියෙනවා. මොනවද කරන්නේ? ඒ උත්තර දෙක නේද ඒකට? ටයිප් කරන්නේ ඕනේ. කියන්නේ පුළුවන්. Yes. Become careful. There was a question about how to obtain a skin graft. We can use several methods. The Humby Watson knife, Humby knife is also modification can be used. And there are techniques about using a skin graft, how to keep the donor side stretched on taking the skin graft. And there are motorized electrical dermatomes. Both these can be used when you are taking a full thickness skin graft. We can use surgical knife, a 15 or a 23, with a 15 within a 23 blade for taking the full thickness graft. We can use 50% dextrose in the event of maggots. But other than which will get the maggots to come to surface because due to the high concentration. Other than that, as a rotation, there's no place in 50% dextrose.
I think Dr. Nirukshan is held up with her surgery, so he went shortly. If not, Professor Bantam with evaluation for patient for routine surgery. So, stay put.
Dr. Nirukshan has joined. Can we make him share the screen, please?
Hello.
Can hear you now, sir.
Okay, so let's start. So can I start now? Hello. Can everyone hear me? Hello. Can you all hear me? Hello.
Yes, sir, can hear you.
Can I start?
Sure, sir.
I cannot hear anything on that side. Can I start? Somebody respond.
Yes, sir, you can start.
Okay, right. Okay. Right. Today, we are going to talk about management of head injury or else traumatic brain injury. Is it clear and loud?
Yes, sir.
Okay, so
Yes.
so patient now you all as interns, now you will be going to your wards, and some of you will be doing the surgical appointments. So first day you will see a patient who is coming to your ward with a traumatic brain injury, right? So then why you should know about these things, right? So most of the time these patients comes to you unconscious. So they are critically ill. Sometimes they will have polytrauma, other injuries, and if they have a head injury, if you have a very limited uh, time, so the margin of error is very limited, so it's time critical, you have to act quickly. So therefore every one of you should know about how to manage a head injury, at least the initial bit of the head injury management, right? So it's very important because all over the world, basically the trauma rates are going very high, especially in Sri Lanka. Over the past few years, we have noticed the road traffic accidents and numbers are increasing rapidly, and most of them are very critical head injuries. So our head injury admissions are going every day. The numbers are going very high. So in Sri Lanka, especially when you're talking about Sri Lanka, is rapidly rising, even several hundred falls rates over the last couple of years. So you as a interns, now when you come across or see a patient, so why you should know? So you should know how to get the information, right? And carry out initial resuscitation and stabilize the patient until your seniors or consultants know, or you refer to these patients to a neurosurgical center, right? And then you should know how to transfer this patient correctly to the correct place. And then main objective of this head injury management is to avoid secondary insult. The first insult, of course, already happened. You can't do anything about it except prevention, right? So, but to prevent the secondary insult, you have to act accordingly, act quickly, so to prevent secondary impact of the brain. So, most important thing of managing any patient is not only in head injury, but even any patient, you have to have a good background information, or other words, it's a history of this patient. So unfortunately, most of these head injured patients, they comes to you, they are unconscious. So then you should know how to find information, right? So these are the basic information I'm going to, you know, the ample history. So uh, you know how to take that, but I'm going to stress on the event or the environment of this head injury. So it's very, very important to know the event. So it's the time of incident. It's very important. Time since the incident is gives a good clue how what has happened this patient since the impact. And then mode or mechanism of injury, whether road traffic accident, fall, gunshot injury, stab, while assault, so whatever. And details, any other details, whether it's fallen from a height, how high he has fallen, and whether if it is in a road traffic accident, how fast the vehicle was traveling, was it a driver or is a pillion rider of the motorbike, right? So these information are very important because it gives us a clue to the impact or the amount of force transmitted to the brain to cause the injury. And the other information that you want is whether in the primary receiving center, whether they have done any management, whether they are given mannitol or whether they are paralyzed and ventilate the patient. So if the patient comes to you with a tube, then you don't know the Glasgow Coma scale of this patient. Then you should know what they have done at the peripheral hospital, right? Whether he had the cardiac arrest, whether he has developed seizures, and then head injury observation chart. You have to look into the head injury observation chart throughout since the admission. And then you should know how you gather the information. So most of these patients, I told you, is unconscious. So then there will be people around you, the eyewitnesses. Sometimes relatives will be accompanying the patient, or sometimes the police or the transport crew. Nowadays we have the ambulance crew, so that they might give you a good history about the incident and what have they done, and the medical notes from the referring hospital. So you have to go through this and quickly gather information and then come to a conclusion, right? So the assessment. So assessment and initial management goes hand in hand. So initial assessment is very important: blood pressure and pulse rate, pupillary size, GCS, neurological status. So these are the head injury observation charts, right? I hope everyone has seen the head injury observation chart. So these information is there with a reason, right? So I'm sure that you as medical students has gone through the neurosurgical appointments. You know what is there in the head injury observation chart. So having the head injury observation chart is very important for early diagnosis of deteriorating head injury, right? So this is other thing that you should know, which I will not go into great detail of the Glasgow Coma scale, but there is a scale that is the universal language that we are talking about head injury patient. The Glasgow Coma scale gives you a gives you an idea about this, how bad is this head injury. So which you know the Glasgow Coma scale, is very easy to communicate with your other colleagues when you are transporting a patient, and also which is a good guideline to give you the monitoring of the patient and also the outcome of the head injury. So bad Glasgow Coma scale patients has a bad outcome. Good Glasgow Coma scale and it's a good outcome. And then again, Glasgow Coma scale is used to categorize the head injury into minor, moderate, and severe. Right? So there I mean, if I go to little bit details, you check the best eye response, verbal response, and motor response. So please go through that, and you should be thorough about this Glasgow Coma scale and how to assess that, which I'm not going into detail. And when you see the patients, you should see these posturing signs. You call it motor posturing, right? And extension posture that you call is decerebrating rigidity. Like, you know, all are going into extensions and medially rotated, right? Decerebration. And then abnormal flexion or decorticated rigidity. It's the elbows going into flexion and then rotated the wrist going into flexion, right? So this is a decorticated, which gives you which level of the spinal cord, which level of the neuron is damaged. And what is this sign? This is behind the ear. You call it battle sign. So which is, if you have to look into that, if you don't look, you will not see which it's hidden behind the ear and under the hair. So you have to look into this. So these are the sign which says the which there's a middle cranial fossa skull base injury. So which tells you it's a significant impact, significant head injury. And what is this? This you call the black eye, right? So it's different to this. This also black eye. It's different. What I'm going to show you right now. This is called panda eye or the raccoon eye. So this and this one, two different things, right? So black eye is mainly a direct trauma to the forehead or the orbit, causing the edema and bleeding in the subcutaneous tissue in the forehead or around the orbit, right? So the blood track under the frontalis muscle to the eyelids, causing eyelid swelling and discolorations. You call it the black eye. But whereas in this panda eye or raccoon eye, it is basically the skull base injury. You can see the difference, right? The eyelids are okay, but around the eye there's a discoloration, right? So blood tracking around the orbit under the skin there, you call it the panda eye or the raccoon eye. So this is an indication of the frontal skull base injury. So it's a battle sign indication of the middle cranial fossa or temporal skull base injury. This is another one. You can see this is the subconjunctival hemorrhage. So the first picture, you cannot see the posterior margin of the subconjunctival hemorrhage. Whereas in the second one, you can see the posterior margin clearly. So the second one is due to the direct trauma. And this one is again the indication of a skull base injury, which is the blood tracking from behind into the subconjunctival space. So you have to differentiate these two signs. So these are the signs that you are going to elicit, right? Okay, so head injury. Here, so basically we say head injury is when there's injury to the scalp, skull, or the brain, right? Like in this, skull aberrations, and sometimes degloving injury of the scalp, or sometimes subgaleal hematomas, and then associated with fractures. It could be the comminuted multiple fragments and depressed. This could be sometimes open when there's a fracture is open to the exterior. You call it the open fracture or compound fracture, which has a high risk of infection, right? And how do you classify by the mechanism of head injury? As like in any other trauma, the blunt versus penetrating, right? The blunt injuries, it could be the high energy transmission or low energy transmission, like in high energy transmission fall or road traffic accidents, which are acceleration, deceleration injuries, right? Or somebody assaulted with the fist, you call it the low energy transmission, right? So the high energy transmission, of course, carries more energy, causing severe injury. And penetrating, low and high velocity. Low one is the stab. The high velocity ones are the gunshot injuries, right? So gunshot injuries obviously carry high energy to the brain, causing significant injury. So what are the modes? RT, I mentioned you about this. RT, road traffic accidents, fall, right? Or accidental fall on the ground, or maybe fallen from height, tree, or the high-rising building, right? Assaults, violence. So depending on these informations are very important to you to categorize or identify the amount of the force that has gone into brain and causing the impact. You should know this bit of anatomy. You should have heard about the coup and contra-coup injury, right? The coup injury is at the site of impact, the frontal area. There could be abrasions, lacerations, or the fracture bone and underlying contusion of the brain. But when you do the CT scan, you will see the behind, the directly opposite of that, there will be contusions. That is a coup and contra-coup injury, because his brain is sort of floating inside the CSF in the rigid skull. When the head moves fast, and the brain lags behind, there's a space creating posteriorly, and once your head stops, brain goes and hit the back of the head and causes the contusions there. That's why you see the contra-coup injury in the CT. Now this is one, you can see the primary injury there, the fracture, and the EDH here. And then you are surprised in the opposite side, there are multiple contusions and the SH. So this is the contra-coup injury, the CT scan. So this is a CT scan of a gunshot injury. The bullet has traversed through and could dissipate in a lot of energy. You can see surrounding cerebral edema, and this is a track. So it causes significant impact to the brain. And there's a stab injury, just cut into the brain. cut through, right? And anatomy, you should know these layers of the scalp and the skull, right? Because which tells you what are the injuries. So the scalp made of the skin cover made of scalp, thin skin, and subcutaneous tissue, and galea, right? And then the periosteum, right? So this the underneath the galea, the pericranium, and between the galea and the pericranium, there's a connective tissue layer. So therefore, your scalp is easily mobile over the skin, which can easily deglove from the head. And then the bone has the inner cortex and outer cortex, right? Underneath that is the dura. Dura has two layers, outer layer, inner layer. In the midline and where the sinuses meet, these two layers are separated and you have the sinus. So underneath is arachnoid mater, pia mater, and then the cerebral cortex comes, right? So this anatomy you should know. And a little bit of these skull bones, so the multiple frontal bone, parietal, these bones you should know. And when you take the skull base, frontal skull base, middle skull base, and posterior skull base, right? So there are several holes, and they are travels to nerves and arteries or the vessels. So you should know this. You can appreciate this frontal skull base very ragged surface. So that's why when there's a trauma, frontal and especially temporal, the contusions are very common in the skull bases because it's ragged surface brain. The moves when this damage the brain, right? And you should know the cortical anatomy. What are the representative area of the brain? The motor cortex, sensory cortex, and the occipital visual cortex. And where the Broca's area, Wernicke's area for the speech, right? So these areas you should know. If there's a damage to the brain, you should know what are the areas involved. This is the normal CT scan. You should be able to appreciate that CT scans are taken several cuts from the skull base up to the vertex. So at several levels, you can see the different areas of the brain. You should not be able to appreciate where the frontal, where the parietal, and where the occipital, and see the brain stem. Right around the brain stem, you can see the around the brain stem. You should be able to see these spaces are very important. They are that says the edema. So when there's an edema appearing, these spaces are tend to get obliterated. So it's very tight. Now this one is normal CT brain. So I was talking about the fractures. It could be linear, comminuted or depressed, sometimes simple or compound depending on the open to the outside. When there's a autoria or rhinorrhea, which indicates the associated with the fracture, there could be a dural defect. So then you can have the CSF leaks. So that means the high risk of infection, CNS infection, if there's CSF leaking from either nose or the ear, autoria or rhinorrhea. So you have to look into these things. Associated with skull base, you can have EDHS, bone bleeding from the vessels, bleeding from the bone. Again, a depressed fracture. So then the intracranial bleeds. You have seen extradural hemorrhages. So it's like this biconvex when in the CT scan, extradural hemorrhage. So because of the dura strips from the brain, it gets a biconvex appearance. Again, subdural hemorrhages, right? It's a crescentic shape. So one side is convex, other side is concave. So it's is the usual shape of the subdural hemorrhage. This is how you see in the CT scan. This is subarachnoid hemorrhage. Usually you see in spontaneous aneurysmal rupture, but even in trauma, major vessel damage, you can have this type of subarachnoid hemorrhages in the basal systems. And usually the interventricular hemorrhage, ventricles are filled with blood. And the cerebral hemorrhage, usually spontaneous. Intracranial, these are the brain contusions, I told you. So there are frontal basal contusions. And then there are stab injuries, brain lacerations. Severe cerebral edema. You can't see any sulcus or gyrus here. So this disappearance, a brown glass appearance. So in that case, you can see the severe cerebral edema. Right? So there are the diffuse brain injury in the MRI scan. You can see the tiny hemorrhagic spots in the corticocellular interface, in the gray white interface. Large extradural hematoma in a CT scan. This is how you see EDH on the specimen. So you can see that outside the dura, under the bone, it's a large extradural hemorrhage. This subdural hemorrhage. This is how you see subdural hemorrhage in the surgical specimen, right? One under the dura. between the brain, subdural hemorrhage. The IVH is again cerebral edema. So you have heard of this Monroe-Kelly doctrine, right? So the brain is consists of a rigid space, static volume. There you have the brain, blood and CSF, right? When there's a mass appearing, so it increases the pressure because this occupies some volume. So initially, according to the Monroe-Kelly doctrine, it pushes out some of the CSF and blood out to maintain the pressure. But when it's at some point, it will exceed the volume and then it start pushing the brain. So it's called the brain herniation. So then this is what happened in Monroe-Kelly doctrine. So it's compensate initial when mass is appearing, the inside pressure is compensated by sending blood and CSF out. But at some point, rapidly rising intracranial pressure, because the further you cannot expel out blood or CSF, then the pressure start rising. So you should act before this reach this point. If you reach this point, then brain will start herniating like this, right? So when there's a mass appear, brain can herniate to the opposite side. You call it midline shift under the falx. Or the central, you can herniate down to the tentorium, you call central herniation. Sometimes the uncus can herniate over the tentorial edge, you call uncal herniation. And then tonsillar herniation, sometimes the cerebellar tonsils can herniate through the foramen magnum, or the brainstem herniate also through the foramen magnum. So to prevent that, you should act before you reach that critical point. And again, you should know this the equation, cerebral perfusion pressure, mean arterial pressure minus ICP, because CPP is the one going to keep the brain perfused. But when the intracranial pressure rises, so then CPP going to go down. So then you have to maintain the mean arterial pressure. That's why very important to maintain the MAP. We call it, neurosurgeons always talk about the mean arterial pressure MAP. Maintain the MAP. So at least you should have the 70 millimeter mercury cerebral perfusion pressure. So if we say maximum tolerable ICP is 20, then MAP maintenance should be around 90. So that's why we are talking about MAP 90. Maintain MAP 90 is very important in head injury. So I told you about categorization of head injury depending on the Glasgow-Coma scale, the minor head injury, right? So Glasgow-Coma scale 13 or 14, and moderate head injury between Glasgow-Coma scale 9 and 12. And severe head injury if the Glasgow-Coma scale less than 8. So I told you primary head injury at the time of impact, which you cannot do much about it. It's a prevention is the only way to stop primary head injury, and then you have to act quickly to prevent the secondary insult to the brain. So what are the secondary insult? Due to expanding hematoma, it can compromise the cerebral perfusion. It can herniate the brain, right? And brain edema also act as, space occupying lesion, and hypoxemia and ischemia, shock. So if the patient is having higher hypovolemia and shock, then it reduces the cerebral perfusion. So you have to treat the shock quickly. And hypoxemia, you have to give the adequate oxygenation to the patient. And later on, sometimes fever infection is another secondary insult, and electrolytes imbalance. So this is the management of head injury. So our goal of management of head injury is prevent the secondary brain injury. That is a very important thing. And also you have to think of this. Most of the patients, over 10% of the head injured patient can have a cervical spine injury. So the cervical spine is also comes priority to you. So unless otherwise excluded, you have to treat this head injury patient, especially severe head injury patient. The cervical spine injury is a susceptible cervical spine injury patient, right? So you have to protect the cervical spine. This is the correct collar, which prevent the flexion, extension of the neck, and rotation. But sometimes you do this type of collars, which does not prevent the rotation. So these are wrong. And again, you should know how to protect the spine. So log rolling and the spinal board, right? So it's very important how to do log roll a patient and proper transport of a head injury patient on a spinal board, right? So like in any other trauma, you have gone through advanced trauma and life support. So basic management is very important, right? So correct positioning and protect the cervical spine and stop bleeding. And you have to manage airway, breathing, and circulation, ABCD. So these are the straightforward. And then you have to do when the patient is stable, you have to do the investigations like X-rays or CTs. Then only will take over from there if the CT is positive, and for the definitive management of head injury. So once you do all these things, it's very important. Most of the, and in the country, in Sri Lanka, we have very nice limited number of neurosurgical centers. So then you have to communicate with the neurosurgical center before you transfer this patient, and giving the adequate information about the patient, the GCS, what you have done, and then you have to inform the receiving center about all the details, and then they can get ready by the time patient receives. But because I told you, it's a time critical management of head injury. We don't have time to waste. So it's quickly you can pass information and correct transportation. We can transfer the patient. So because of the time factor, I will not go much detail into these things. And yeah, CT scan, indication for CT scan. So any patient at any time, if GCS is less than 13, is an indication for CT scan. So sometimes initial GCS is less than 13, but 13, 14. But after 2 hours, if it is not improved to 15, then again it's an indication. And suspected open or depressed skull fractures, evidence of skull base injuries, I told you. And if there's any seizures and any focal neurological signs are the indication for CT, right? And if the post-traumatic amnesia is more than 30 minutes, and persistent vomiting, and any coagulopathies, or if these patients are on antiplatelets or anticoagulants, is very important. Or sometimes hemophiliacs, congenital coagulopathies, right? And if you cannot exclude the cervical spine clinically in a GCS 15 patient, so then it's an indication for include the cervical spine also in the CT scan of the brain. So it's very important to exclude cervical spine injury. So to prevent secondary insult, you have to maintain, I told you, to maintain the mean arterial pressure and control the intracranial pressure. So intracranial pressure can be controlled by giving mannitol 3% saline, or when indicated, appropriate surgical intervention to remove the blood clots like EDH or SDH. So you have to give oxygen. If you think that patient needs ventilation, put the tube and ventilate, right, before you transfer. So to prevent the secondary brain insult. And again, in long run, so you have to correct electrolytes, very important, and temperature, and fits control, right? But usually I don't give prophylactic antiepileptic, that's not indicated. But if there are evident fits, you have to give a start antiepileptics. So to you, the take-home message is it's a timely management. It's a time critical. You don't have time to waste. Appropriate correct history, and you have to protect the cervical spine. If you think that patient needs intubation, always better to intubate. And CT scan, proper communication with the neurosurgical receiving center, proper transfer, and for the definitive management. So these are the take-home message for you. I think I've done, and it's a bit fast though. You got my point. I think I'm done. Hello.
Yes, sir. Thank you, sir. Thank you very much.
Okay, right. Thank you. I'll quit then.
And the next lecture will be by Dr. Satish Gunasingham, consultant surgeon, on writing diagnosis card.
Hi, good morning. I hope you can see my slides. Can you all see my slides, please?
Yes, sir, can see.
Yeah. Good morning. So this is another very important topic. We talk about a lot of management issues. Primarily, we put a big effort and manage patients, and when the patient leaves the hospital, the only proof that the patient has about his or her management is a diagnosis card. So we can't trivialize a diagnosis card when we discharge a patient. It's a very important document, and I think we should work very hard to write a good diagnosis card. Otherwise, the patient is lost. If the patient is admitted in the hospital, there'll be no details about the patient's management. So why should we write a diagnosis card? I mean, there are books also, but it is the document that contains all details about a patient's hospital stay. Once the patient is discharged from hospital, it's the only document that patient carries with details about the patient's condition diagnosis, clinical details, investigations, treatment details, and follow-up details. So this is a very vital document. Now, a person, let us assume there's a poor villager who is not quite aware of his problem. When he leaves, that's the document he carries. So wherever he goes, that diagnosis card, the document should contain details about the management. Now, this is an aspect most of the time people tend to neglect. Some departments, they don't give a diagnosis card, thinking that it will be a bother to the patient. This happens in some of the medical departments in Sri Lanka. Bronchial asthmatic, chronic asthmatic. No, it's a big problem. No, patient is not a problem at all. But the patient has a right to carry whatever the illness, a diagnosis card. Actually, in the diagnosis card, when you become interns, you need not write all the details about management. You have to write only a summary. So initially, you will find that it's a challenging task, but when you go on writing these diagnosis cards, you'll find it's not a difficult task. But to ask what the patient's problems were, list the problems, what were the solutions given to the patient in the form of medication, surgery, or procedures, and also what is the follow-up plan. That is what is exactly you had to document. So prioritizing what you are going to write, you get with this experience, and I'm sure there'll be senior guidance on this. So it's a vital document, and it should contain all essential details regarding management. I mean, you need not put serum creatinine done every day. You can give the trend. How was it initially and how it improved or deteriorated later on, like that. So, because if you go to document everything in the PhD, you'll be giving a diagnosis ticket with all the details. So this is the ability for you to summarize the patient's management, but the details should contain details that are required if any other person looks at the patient anywhere else or even in a clinic. So this is very important. Third, it should clearly indicate details about the hospital. Now there's a tendency, the bad tendency we see in Sri Lanka. Units, they give the diagnosis card, but they don't identify where the patient was managed, who the consultant in charge was. Now that is also a very bad trend. Now that is shirking responsibility. It should clearly indicate details about the hospital where the patient was managed, including the consultant's name. As professionals, we have to be accountable. And these people, poor people, rich people, different types of people, comes to us with a confident repose on doctors that we'll give the best possible care to them. So if we don't give details about where he was managed or where she was managed, we are letting down the patient. So we have to be accountable. We must say who managed the patient, where the patient was managed. Most units, in some of the units in Sri Lanka, they don't put the consultant's name. They don't put the consultancy or the hospital name. And so we are lost when we get a patient. So accountability is one. We are not going to take umbrage or power telling that we are not managing the patient. Those names should be there. It is essentially a right of a patient to have a detailed diagnosis card. And nowadays, litigation is coming up over and over again. And if you don't have patient does not get a adequate diagnosis, he can be litigious and he can go to courts also. So we have to be careful. But we have to write a good diagnosis card, not to take power from cases, but as a good behavior, as a good doctor. Then you need not worry about cases. So it's a summary of management. It should contain all details. It should be details about the managing consultant's name, the hospital, and it's a right of a patient. There are different formats of diagnosis cards. There's a short version, Health 16A. I'll show that to you. That is commonly like a small OPD sheet-like card, where if it's a brief admission, small problem, still you can document in such a card. We do in almost all the units in Sri Lanka. You summarize the problem and give a brief card. And there is a formal diagnosis card, Health 83A. That was an older version when we were interns writing those cards, but now we have a new detailed version done by the Ministry of Health. And that's a very comprehensive card, which if you take a liking and if you take a trend of it, you can write it in. And you would have seen in situations where there are lots of details are to be documented, we get an exercise book, and you would have seen in some of the units in Sri Lanka, I mean, there's detailed documentation, long follow-ups, we give a patient an exercise book. Now that is a very important thing. An exercise book is used with the provision of follow-up remarks. So it's a diagnosis card, it's a diagnosis book or a management record book. A diagnosis card is one term that we use. So second category, formal diagnosis card, is the general one that is used. So whatever the surgery we do, whatever the treatment we give, we have to give details in this formal diagnosis card. L16A is this type of card. I'm sure, I hope you can see this. This is a very brief card where you can, for a small thing, if a patient comes with a laceration, if you're severe, you can give a brief card, but you have to give the plan. But this does not contain that type of details, but this is a brief card you can give in a sort of a simple problem, which doesn't need much follow-up. We need 1 or 2 follow-up with it. It gives the name, what is the particulars of the therapy we have given and what type of treatment. This is a very simple card that we see. This is the 16A. It's available in all the boards. This card is Health 83A. This is what we used as intern, and it was here in Sri Lanka until recently. Now this has been superseded by an old version. I'm sure all of you know. It was demographic details. This is a old card developed in the 1960s and 70s. And formerly this was sort of meant only for the Colombo General Hospital. The National Hospital was known as Colombo General. And it became national. And it is a very superficial type of card where you have all the spaces right these things. So now this has been replaced by Health 380A, the new version, which is a current and comprehensive card that has a lot of details to be entered. But once again, you can do this very carefully. When you have the free time, you can write the demographic details, or you can fill up things. I'll go in detail because this particular card gives a lot of details that you have to fill in. Now remember, maybe some are not very practical for you to fill in. And whatever the practical things you have to fill in. I mean, this is very comprehensive, but this gives a lot of details. But in a doubtful situation, small problems, you can go to 16A, otherwise you can go to 383A, new version. So this is in 4 pages. It's a card, foldable, and it has a larger format and as well. Now they have gone back to the smaller format. They have printed 4 million copies of this particular card, the Ministry of Health. So I think we should use it really well. If we do it really well, we can do a lot of information for the patient. So the personal details are there. Personal health numbers are sent by hospitals with barcodes, so yeah, computerization. Telephone number, if you don't have the time, I mean, you can ask the nursing officer, right? NIC is vital because sometimes it can be the only search, record which you can use. And allergies are important. On the right side, on your right, you see these details to be entered. Patient's name obviously has to go there. Then the BHT number we have to enter. Then as you go down, there is, and at the top you have the hospital as well. Unit details, gender, age, date of admission, date of discharge, that's a must. Principal diagnosis, if you have a diagnosis like a patient with, let's assume the patient comes with the cellulitis of the left lower limb, with diabetes mellitus and ischemic heart disease. Principal diagnosis would be cellulitis of the left leg. Comorbidities, also you have to mention. I mean, surgery, it's very important to mention comorbidities, especially, I mean, as we know, we have to mention about hypertension, ischemic heart disease, bronchial asthma, and also ischemic heart disease, and also diabetes mellitus. Now, these are important things to mention, comorbidities. And sometimes what happens in a patient with a diagnosis card with inadequate information comes to a hospital, and we don't know the details. Sometimes we can't discern what the details are. So it will be nice if you can document. There's another thing called a transfer form, which beyond the ambit of my lecture today. When a patient is transferred from one center to another hospital, that also, I mean, we have an old form, but that contains limited information. That also has should give the details. In a good center, what they do is they give a transfer form and also a diagnosis card, and they say transferred such and such a hospital in the diagnosis card for further management. So this is a right. Now just imagine one of our family members get ill, had surgery, and he's not given adequate diagnosis surgery. No, that's a criminal. He should give a diagnosis card. So these are the basic demographic details and principal diagnosis and comorbidities. So those have to be mentioned. So once again, going back to the, I mean, once again, the page 1, comorbidities I mentioned, and we have to ask how the patient came, by himself, referred, by whom, transferred, from which hospital. Then when you are discharging the patient, transferred out to another hospital. So I told you, with the transferring out, also you have to give a card and self-discharge. Then there is a habit in our country, which is not that common. A patient is leaving against medical advice, you shout at the patient to go to another place, get it done. You can't shout at a patient. The patient is going against medical advice, still we have to give a card. We have to indicate patient has been managed in this way, but the patient wishes to leave against our advice. That has to be indicated. So now there are not in surgery, but this is notifications. You know what the notifiable diseases are. Medical certificate is also very important. Some patients can get multiple medical certificates, so issued or not. Insurance form filled, well, in orthopedics and certain areas we have to fill insurance. So that is important. Then at the lower part, you can consultant's name and stamp. That is the most, that's a missing element in some of the cards. We don't know who the consultants, where the patient was managed. So what they do with the intention of evading future admissions if a patient comes. Now that is a very bad thing. We should never do that. We have to be accountable and we have to take responsibility. So always the consultant's name and the stamp should be there in a diagnosis card. Remember that. If you don't that, it's very unprofessional. It's very unethical. And the first name, absolutely, you have to indicate. You have to have the guts. You have to have the moral duty to write your name and signature. So these are very important things. So this is the first page: demographic details, principal diagnosis, comorbidities, modes of admission, modes of discharge, any other forms were issued, and consultant's name and stamp, and MOQ. Second page is like the traditional diagnosis card, presenting complaint, history, examination. That also you can be very brief. You are not going to sort of write a comprehensive history like a medical student. It's their time. Now you are evolving, you are changing from medical student to doctor. So presenting complaint, history, examination, very briefly, you do the relevant things. And treatment and surgical procedures. What type of treatment was given? So that you have to brief. That's a challenging part. So as you go on in your work habit, when you become our interns, you will realize these are the general things we do. So you can list what you have done. any challenging things, and also in surgeries, what type of surgery was done. And also in a surgery, when you write about the operation, you can write incision, findings, and the procedure. And now incision is not there if you're going laparoscopic or minimally invasive surgery or endoscopic surgery. So it will be relevant, but it's very important to mention what findings were and what type of corrective procedures or many other procedures were done. So that is very important when antibiotic given and what was the post-op period, whether they are appropriate. I mean, this space may be inadequate, but still it hits to give a brief picture of what really happened with the patient as post-operative bleeding. Patient had any post-op infections, what their wound adhesions. Briefly, you can mention the patient had a wound infection, patient DVT, and I mean any other problem you are talking about. So these are very important things. So when we look at a patient, we always see, and this will be useful not only to any other person, but also the people who are when you are following up the patient in the clinic. Coming to the third page, there's space for various things. On the left side, you have investigations. So you can list the investigations, but if you are doing investigations every day, you are not going to write all the day's investigations. But you can give the trend. Falling, initial creatinine gradually fell, and final on discharge this one. HP was this, and this was the trend. Otherwise, you'll be documenting all the details, and you will have to have your own secretary to do work, which is not practical. So you are doing heavy work of internship. So that is very important. So investigation. Histology is available. It's very unlikely for patient has had surgery, histology to come within the patient's hospital stay. Sometimes it may come, but it should be depending on the efficiency of histology departments. So if there is report, CT reports, you can summarize. Don't write entire CT description, but write the summary. What was found? Then what was the condition of the patients on the right hand side? That's the lower part of page 3. You got to write what is the situation. Now these are, I mean, it looks very challenging, but it's a joy. It's immense satisfaction when you document. When we were interns, we used to work till night writing diagnosis cards, underlining. And you enjoy, that's a document you do, and this reflects the quality of work done by you and your department. Go to the last page, medications on discharge. Very briefly, you can mention what type of drugs were given. But in a department which is about 15, 20 drugs, still you have to document. In this thing in Sinhalese, it has given කරුණාකර ඔබට නියම කරන ලද ඖෂධ වෛද්‍ය උපදෙස් පරිදි පාවිච්චි කරන්න. I doubt very much our patients read these things, but you have to highlight that area. Because sometimes patients will not bother, some patients will not bother what their problem is. They'll not know who the consultant was, the person will not know. So at least you have to educate the families about this. It's very sorry state, but still you must give somehow services. I think it's to write in Sinhalese underline. You can underline or highlight page and at least tell the patient. And you don't just write a card and just shove it away and go from the ward. You have a moral responsibility to tell the patient what the problem is. Discharge plan. Now, that's another long-term follow-up. So diet, lifestyle, behavior, very brief things in surgery, depending on how patient is going to follow it up. If the patient has form of cancer surgery, we can tell whether the patient is being referred to the oncologist, whether the patient has had a multidisciplinary team meeting, what type of things we are exactly going to do. It's very variable from patient to patient. You have to document. I mean, these should be brief documentation, not, I mean, voluminous essays, but just in point form to cut down the problems. That's very important. Next one is follow-up details. You must tell patients about, sorry, I can hear some conversation. Sorry, I can hear some other conversation going. So then you have to document follow-up details as well. At least tell which, I mean, you can have seal here. What clinic has to come. Then now what I told in instruction single or Tamil, I mean, if you have the time, that would be nice to document. සඳුදා දිනවල උදේට සායනයට පැමිණෙන්න. වාර්තා සමග පැමිණෙන්න. Or in Tamil also you can do this. Referral note, if you are going to refer to some other patient, it will be another document you can write. So now another important thing is patients, last one before the last, if a patient has an injury, some trauma, some violence, then the patient has to be seen by the judicial medical officer. Patient surgery, trauma, then you know the MLEF, medical legal examination form you would have done in your forensic medical case. Make sure that has been filled, and with the JM, because if you release a patient after some violence or some criminal offense who has been subjected to a criminal offense, that becomes a problem. So you have to document. Then these are the important things in the diagnosis card. So it varies from which department you are going to work. Now we are focusing on surgery. So these details are actually, if you look carefully, if any one of your relatives get unwell, these details are very important. Otherwise, and also you must tell the patient, please have a photocopy of this card somewhere else or digitally store it. Sometimes the young children, they digitally store their parents' details. At least take photographs. But most of the time, people come saying that it went into the floods, it was taken away by someone, it was lost in the bus. It's a very common thing in our country. But always make sure that they have copies, at least a digital copy or at least a photocopy somewhere else. That's very important. So from that, I hope you have got a general idea why we should do a diagnosis card and what details should be included in a diagnosis card. So all patients, so in summary, all patients who are admitted to for treatment or management to hospital should be issued with a diagnosis card with all the essential details. It should identify the name of the consultant, sorry about my spelling, hospital. It should be there. Even a patient who is leaving against medical, sorry, I'm missing word against. A patient who is leaving against medical advice, use the word LAMA, we issued with diagnosis card with all management details. Without an adequate diagnosis card, no one can infer, no one can know what has been done to a patient in a hospital. Even in your own unit, when the patient comes, you can't tell that. We have to document so that there will be no questions to be asked. So this is what I call an adequate diagnosis card. It can be diagnosis book also. So all patients should get it. Accountability is important. Even a patient going against medical advice, LAMA should be issued with a diagnosis card with all management details. And without the card, you can't get any details. And also, our country, there's another tendency, diagnosis card written with the OPD, the drugs, and it could disappear. Some, not I know, most don't disappear. At least you have to counsel, tell the patient, make a clinic, maybe hitting a gun. It's told by our good house officers, you have to tell briefly, in addition to the issuance of the card. Sometimes some words the nursing officers give the description. It should be contain relevant details and trends, and it should be neat and legible. Our handwriting is so very variable, but it's very important that you have all the details neat. You need not be sort of mutuketa type handwriting, but you can have a neat, legible handwriting. It's very important. So that's important. For finally, writing a diagnosis card is a challenge, but it's rewarding. It takes time and commitment. Sometimes interns we used to write diagnosis card late in the night. It was a joy. It completes our responsibility towards a patient who's being discharged from hospital, and it imparts immense professional satisfaction. Right? As an intern, even still as a consultant, telling patient what it is, documenting those things, imparts satisfaction. Surgery doesn't mean cutting. Surgery means assessment, optimization, performance of surgery, adequate follow-up, and patient education. A lot of people think surgery is just cutting. No, it also documentation is a very important part. So it gives immense satisfaction. And if you sort of fail in your responsibility if you don't document, and it also reflects the quality of care given to the patients. And sometimes when you look at the diagnosis card, we know there's this particular household has a super future, who has a good future because he or she has written it very assiduously with a lot of keenness. And sometimes we have the joy of coming across our diagnosis cards written late in your career as an old man. I have come across my own diagnosis card. It becomes history and it gives immense joy and satisfaction. So I hope all of you have understood the importance of a diagnosis card in different forms and the importance of conveying information. They come to us in confidence. We document what we have done so that he or she knows, the future follow-up teams know, and any other center they'll come to know. And litigation, he'll have the evidence. Insurance, he'll have the evidence. So everywhere, it's a vital document. And I wish to thank you all for patiently listening to this lecture and wish you all the very best in your careers as doctors. And I'm sure you all will be excellent doctors. Wish you all the very best. Thank you. Any question? Discharge card. There are two questions. Discharge card given to a patient who's been, yes, you have to give. You have to give a transfer patient also. Always you have to have a discharge card. This new card gives provision. Brief summary. LAMA also you have to give a card. So what should be written in the section? Patient's condition at the time of, no, here we can say, I mean, most of the time patients are cured or patients have recovered or whether the patient's been transferred to another unit. Patients going for further care. Those things have to be, and normally we don't discharge a patient who is in a bad condition, but still have to document if the patient going against their medical advice, what the state of the patient, right? Any other questions? What should be in red color? That's a personal preference. As in case I used to underline in red. Well, you can use any color of the spectrum, I mean, rainbow, but you can highlight certain kind of thing. I used to use asterisks, underlining things, headings. An important thing the patient should know. You can write in Sinhalese or Tamil, so that it's up to you. Can we choose 16A or depending on the duration of stay? Well, 16A can be used in very brief stays for small things, but not in all cases. Small case of cellulitis, uncomplicated laceration, then you can use it. It's a very subjective thing. And if you think that of information has to go in, important, then you have to go for the 383. Any other question? So once again, I have overrun by 2 minutes. Once again, wish you all the best. And I'm sure 383 is available in all hospitals. Have a look at it. And excellent documentation. It's an important attribute of a good person. Wish you all the best. Thank you very much.
Thank you, Satish, for that excellent talk on how to write diagnosis card. And I think it is very, very important. The diagnosis card carries a lot of information, which is very important for patient management. So I can continue the program. So the next topic that we are going to discuss is about preoperative assessment, preoperative optimization. I have slightly changed the topic. The topic is actually preoperative evaluation and preparation of a patient for routine surgery. I would say rather than preparation, optimization, because as we all know, we are aiming at patient safety and good outcome. So in order to get good outcome and successful surgery, patient has to be prepared for the surgery optimally. So when you are medical students, you may have had this talk during your lectures. So I am not putting any slides. So don't try to jot down what is in slides. What is important is to get everything into your mind and practice them. So if you have any questions, please ask or post, right? Now, if somebody asks, what is the basic difference of a patient who's going to get admitted to a surgical ward or a medical or any other ward? Is there what is the basic difference? If a patient is going to get admitted for a surgical ward for surgery, or can you hear me? Hope all of you can hear me.
Second.
Okay. Right. So, so if somebody asks what is the basic difference, in my opinion, the basic fundamental difference is that a surgical patient who's undergoing surgery will have to undergo anesthesia. Whether it is local, regional, or general, patient has to undergo anesthesia and then the procedure. If a patient is going to get the procedure done under general anesthesia, you may be giving medicines while the patient is under anesthesia. And for example, if the patient develops any reaction, patient can't express him or herself. So therefore, in whatever the surgery, whether it is a minor, intermediate, or major, all the patients, when you assess the patient, the first part of the assessment is history taking. In the history, allergic history is a must, right? So it is very particular in surgical patients, right? So therefore, you have to take a good history, and that should include the allergic history, and also history should assess the patient's comorbidities. For example, diabetes. If the patient is having diabetes mellitus, the patient's control should be assessed, right? All the other non-communicable diseases, hypertension, ischemic heart disease, all those things has to be attended to, and the blood pressures has to be controlled. And if necessary, you have to get the opinion from various other specialties, endocrinologists or cardiologists, to make sure that the patient is optimized for surgery. Now, you assess the patient for surgery, there are several investigations that you do, right? So I always tell there are no basic investigations or advanced investigations. One investigation may be very basic type of investigation for one particular surgery, but it may be most important thing for other surgery. So investigating the patient are of three types investigations. One is to diagnose the condition, you do certain investigations, right? And then another set of investigations are there to see whether there's any complications of the primary disease, or if it is a malignancy, to assess the stage of the cancer. You do second set of investigations, and the third set is that the third set is for see whether the patient is fit for that particular surgery. So that way you should assess the patient by investigations. Then, more importantly, consenting the patient, right? So, consenting the patient, talking to the patient. Of course, if you are not sure about the surgery as a house officer, what particular surgery is going to be done, you should not try to take the consent from the patient, because you may not divulge the proper information to the patient. Sometimes you may give wrong information, and so I don't think it's a duty of the house officer to consent the patient. Always you have to take the consent. Now in government setup, you may have seen as medical students, when the patients are getting admitted, the nurse gives a blank paper to sign. Sometimes it may be the side of the first page of the bed ticket as a consent. That is not acceptable at all. So consenting should be done by a senior person, not by the house officers, right? If you can tell about the procedure, but proper consenting has to be done by senior house officer or registrar, senior registrar, or for the consultant for that matter. Because it's a legal bed ticket is a legal document, and consenting has to be done properly. So all the possible things, complications, alternatives has to be discussed with the patient when you take the consent. So if you are not competent enough, don't take the duty of taking the consent. You can ask from your consultant, and then if consultant says, okay, tell these things, and then explain these things, then you can get the consent from the patient. But otherwise, if you're not sure, don't discuss anything about the patient. You delegate that duty to a senior person. That's number one. Then, not only the patient, you should communicate with the patient's relations also in preparation, right? Maybe the immediate relation, husband or wife, or maybe the daughter or the son, right? So you have to communicate and see whether they have understood what is going to be done to their relative. Because it's very important, because if something goes wrong, the surgeries are associated with complications. Complications they are always, so you have to accept the complications, and you may have explained the complications to the patients and their relations, provided the patient is agreeable to discuss their disease condition with the relations. You should always discuss. If the patient says yes, the patient doesn't mind discussing the patient's disease condition with the immediate relatives, you should always communicate with them, because if there's a complication, after the complication, if you try to explain to the relatives, this has happened and this is a possible complication, there is always, people tend to think something has gone wrong with the surgery, that is why this has happened. But if you have explained to the patient and the relations prior to surgery, these are the possible complications, then unfortunately, if such complication happens, they understand that this is a prior possibility and it had happened. For example, let's say laparoscopic polycystectomy, the patient is coming for laparoscopic polycystectomy, and bile duct injury is a known, well-recognized complication. 0.2 to 0.4% of the people will get bile duct injuries. So unless you have told this to the patient, unfortunately, if that particular patient gets bile duct injury, they tend to think that it's the fault of the surgeon this has happened. So it should not be the way, right? So, so communication with the patient and the immediate family members is also part of the preparation, right? So then we'll come to basics ways how we are going to prepare the patient. It depends on the surgery. Minor surgeries may not need many preparations, right? But intermediate and major surgeries, patient will need preparation, obviously. And in major surgeries, all the investigations, cardiac assessment, respiratory-wise optimization, those things are investigation-wise, you have to do it. In addition, you have to optimize. For example, pre-operatively, some patients may need extensive chest physiotherapy, right? Then the nutritional assessment of the patient, and nutrition has to be optimized. The patient is undergoing major complex procedure involving many bowel or anastomosis inside the abdomen, and all those things. And for the wound healing purposes, the patient's nutrition has to be optimized. If the patient's hemoglobin is low, if you have adequate time, at least 3-4 weeks prior to surgery, then you have to optimize hemoglobin levels, not by giving blood, but you can discuss with the hematologist and start hematinics, and then there's ample time to improve the hemoglobin levels, right? Because giving blood is not the best way to improve hemoglobin, right? And you may know blood transfusion has a lot of adverse effects. Therefore, if you have time, optimize the hemoglobin level with hematinics is the best way, and the dietary proper dietary advices. Then about the albumin levels, as we know, wound healing depends on patient's hemoglobin level, patient's albumin level. So those things has to be optimized. So what are the other specialties you will need in optimizing your patient? Of course, physicians, endocrinologists, cardiologists, you need to liaise with them very well. In addition, dietitians and physiotherapists. So those are the group of people you should be communicating with in optimizing your patient. The physiotherapists, you should talk to the physiotherapist and get some physiotherapy prior to the surgery. And you can start this optimization when the patient is coming to the clinic. In the clinic, you will, your consultant or the senior registrar or the registrar will give the date, and date will be most of the time in maybe 1 or 2 weeks later, or even more than that. So you have ample time to optimize the patient. There are certain graduated exercises will improve the patient's exercise tolerance, which is very important in fast recovery. So those are the aspects you have to deal with. Then you have to identify there are certain conditions where you have to operate, but those conditions are associated with complications. So you have to identify whether there are complications in these conditions. For example, if the patient is coming for bile duct acceleration to get the CBD stone out, or for that matter, if the patient is having obstructive jaundice and coming for major surgery, patient may be having subclinical cholangitis as a part and parcel of the obstructive jaundice. So you need to identify whether the patient, when the patient is admitted for surgery or surgical intervention, whether the patient is having any complications of the disease itself. I'm not talking about metastatic disease. Metastasis also, when the patient is getting admitted for major surgery, the patient may be having metastasis at the same time. For other conditions, there are, like cholangitis is a complication of obstructive jaundice. You may have admitted the consultant may have admitted the patient for maybe for ERCP, maybe for People's procedure, but the patient may be having subclinical cholangitis. So in such situations, you have to detect the cholangitis and treat prior to the surgery. In the same way, similar obstructive jaundice patients may be having coagulopathy because of that obstructive jaundice. So you have to identify those complications. So there are a set of investigations that you do. That is the second set. I told first set of investigations you diagnose. Of course, when the patients are admitted for surgery, that set of investigation has been done. But the second set, to identify the complications of the disease, another set of investigations needs to be done. For example, it is for cholangitis, to diagnose cholangitis, patient white counts has to be done, and also CRP levels, and the history-wise, the patient may say patient is having fever, sometimes chills. It may not be very prominent, but you should be able to identify and then inform your seniors that this patient is admitted for Whipple surgery, but patient has some clinical evidence or clinical evidence of cholangitis. So surgery may not be possible on the due date. Don't be hesitant to tell that to your consultant or your seniors, because sometimes your seniors or the consultant may not detect that. Consultant may have seen the patient in the last clinic visit, and the patient has come to the ward, and it's your duty to identify such complications, right? Then, if the patient has admitted for a surgery for malignancy, other important thing is now the MDTs, multidisciplinary meetings are happening. So patients are discussed in the MDTs, but because of constraints in theatre timing, MDT or the decision to operate would have been taken maybe 3-4 weeks prior, or sometimes even before that, and the patient's surgery may have been postponed several times. The patient is coming after maybe 2-3 months of 2-3 months after the decision was made to operate. So patient's disease condition may have changed by the time the patient was admitted. So therefore, even though the patient's documents or the clinic book or the admission letter says this patient is admitted for, let's say, anterior resection, don't blindly prepare the patient for anterior resection. You assess. You see when was the last imaging done. You have to see when was the last colonoscopy or a sigmoidoscopy was done, right? If it is long time before, always it's better to reassess it and redo if necessary, because disease may have changed, and your if you detect these things prior to surgery, obviously there are many steps to be taken. Your operation may change. You may decide to give neoadjuvant treatment if it had not been given to the patient, and then now the stage may have changed after new imaging. So that type of assessment, you are the one as a house officer should initiate. So the house officer has a very remarkable responsibility in optimizing the patient. So you are the first contact with the patient. You are the first contact with the patient's relation sometimes when the patient comes to the ward from the medical team. So you have to start the assessment and start the communication process. And that communication process will go alone until the patient is discharged, right? And that carries the image of the unit, your communication with the patient, right? Your communication with the relations. Of course, nurses will also have to play a part, and that is the image that is carried by the patient and the relations about the unit. So preoperative optimization and the assessment, if I come back to the beginning, starts from the history, right? In the history, you have to identify patients' comorbidities, and you know the diagnosis, you know why the patient is admitted, what is the surgery. So in the history, identify the comorbidities. If they were not identified, if there are identified comorbidities, you have to make sure that they are optimized for surgery, right? Patient may be on antiplatelets, blood thinners, anticoagulants. Make sure that they are adequately stopped, or bridging agents have been started. So you need to contact your cardiologist and maybe the hematologist in getting these things sorted, right? And then nutritional assessment, optimizing the hemoglobin level, optimizing the albumin level, optimizing the patient's exercise tolerance, right? Preoperative physiotherapy in certain conditions, right? So those are very vital as far as the outcome is concerned. Then there are certain conditions like in obstructive jaundice, the patient's clotting mechanisms may be deranged. So those things has to be adequately optimized, right? And don't wait till the patient is sent to theater to trace the INR report of the patient, which was sent maybe 2 days ago, right? Then major surgeries may need blood and blood products. So you have to always discuss with the blood bank and make sure the blood group is available, and certain blood products may be necessary. For example, in certain conditions, we may have to give fresh frozen plasma or sometimes clotting factors. So discuss with the blood bank and get those things ready for surgery. And then other important thing is when the operations are done in organs where paired organs, right? It's the duty of the house officer during the evening, the previous day evening, make sure that site is marked, right? So surgical site marking is a responsibility of the house officer. So make sure that you carry a indelible ink, right? A pen, and mark the site properly. That is very, very important, right? Because there are many instances the wrong site has been operated, then the surgeon will fall in trouble, right? So these are the things in optimizing the patient. Are there any other questions you can ask? I can answer. So any other questions on this subject? You can't forget about the anesthetist, right? All these major operations, or if there are comorbidities, the anesthetic referrals would have been done from the clinic itself. Or if you detect any problem while the patient is in the ward, always contact the anesthetist and inform them such and such a patient is coming for this surgery and this problem is there. Please come and assess the patient prior to surgery. So that communication you should develop with the anesthetist always. Any questions?
Yes. Questions can ask Professor
Yeah.
Dagamagi on chat box or unmuting yourself.
In chat box, are there any questions? I don't have any questions in the chat box. So you can.
Thank you, Professor Bhavantagam, on the detailed lecture pre-op evaluation and preparation of patients. Next lecture is by.
Thank you very much.
Thank you, sir. Next lecture is by Dr. Minoli Joseph, consultant surgeon on career surgery and work-life balance.
Thank you very much. Hope you all can hear me well.
Yes, we can see you.
Okay, right. So I think our junior doctors got a very good idea about all the clinical aspects of becoming a doctor. And I think this is a very important topic. So this is regarding career in surgery and how to balance work and life in a career in surgery. So I'm a consultant cancer surgeon attached to Kandy National Hospital, Kandy. Right. So let's see whether it's tough as they say, or you know. So first we will talk about how can you become a surgeon. So if you want to become a surgeon, it's about 8 years program, maybe a bit less than that, a bit more than that, right? So how to become a trainee in our training program. So how to become a registrar. To become a registrar, you have to pass MD Part 1, or now it's called the Common Selection Examination. So in this Common Selection Examination, they choose registrars for general surgery, for ENT, for eye surgery, and also for orthopedic surgery. So this is a new concept about, I think this year only it started. So to become eligible for common selection exam, I think you all should know it now onwards, because before choosing your internship appointments also, it is very valuable. So you should hold a medical degree registered with the Sri Lanka Medical Council. And also you have to complete an internship recognized by Sri Lanka Medical Council. Apart from that, to do surgery, you have to complete 1 year post-intern work in Sri Lanka. That is after internship. Sorry about that. Hope you all can hear me.
Yes, we can hear you.
Okay, thanks. So here the coverage is not really great in Candy. Right. So apart from those things, you have to give a medical certificate indicating that your mental and physical fitness is good enough to become a PGIM trainee. Also, your health conditions are in a good, you are having a good health condition. So after that, only you can sit for part 1. So in surgery, now comments examination, there are 2 parts. So common selection has 2 parts. One is multiple choice questions. The other one is the OSCE. So I'm sure you all are right. You all know what are these components are. You all have done OSCEs. You can only sit for OSCE if you pass MCQs. So that is the main rule. So MCQ paper has again 2 parts. So it mainly assess about the basic sciences and core principles of surgery. So actually, if you are a good first year student who did anatomy very well, you can easily pass this MCQ paper. So it's mainly the first year anatomy, physiology and pathology they will ask in this paper. So that the part 1 is that. So there are 60 questions in part 1 and those are true false. So as you know, in one question, you have 5 subheadings. So in this one question, you get for correct response 1 + 1 and incorrect response -1. And the negative mark won't carry to the following question. So as in your like the normal MBBS exams. So there you have 3 hours and you have 60 questions to do. Next, so in that one, as I said earlier, mainly they will ask about anatomy, physiology, pathology, pharmacology, and microbiology. And then they have divided also what anatomy you have to give, like the most important thing is anatomy, then physiology and pathology. So pharmacology and clinical microbiology, not much. So when you are studying, you know which ones you should study better than the other ones. In part 2, it's 1.5 hours duration paper. It has single best answers. So not like us, we didn't have much single best answers when we were students, but I'm sure you all know a lot about these single best answers. Must be much better than us doing single best answers. So it has 50 questions. Each question has, we will give 3 marks. So that is 150 marks. So in these 50 questions, so they will ask about a little bit about surgery also, like a senior house officer level. So core principles, there will be 30 questions. Trauma, there will be 10. Critical care, 5. The radiology and imaging there will be 3 questions. And stats, there will be only 2 questions. So this is how it has divided. They have divided it and you will get it in the exam. So those are very clear cut. Like these days, everything is very clear cut, very transparent. You know what you will get. So nothing is a surprise when you go to the exam. So in the MCQ paper, this part 1 and part 2, both you should pass to be eligible to sit for OSCEs. So you can't get from part 1 75 and part 2 40 to pass and go for OSCE. Then you have failed the exam. So each component you should have minimum 50% marks. And then only you will go for the OSCE. So there is about 3 weeks duration gap between the MCQ and the OSCE. So in OSCE, objective structured clinical examination, there will be 12 stations, and each station, it will be about 10 minutes, and there will be 2 examiners in each station. And then they will assess you and they will give you a mark. So what are the things they will assess you regarding? They will assess you regarding the surgical knowledge and the application of your basic sciences, these anatomy, physiology, pathology, everything, how you will apply it in day-to-day practice in a clinical setting. And also the analytical and interpretative skills, how you will manage, and also these technical skills. So technical skills like how to suture, how to put a tracheostomy, or how to put IC tube. So those things they will check in that station. So these things are new ones. So that's why you have to at least do 6 months surgery appointment to sit for MD Part 1 or Common Selection Examination. The other things, the most important things which they didn't check earlier when we were doing exams, the communication and the professionalism. So for communication, they will ask about information giving, one question, and information gathering. And also for professionalism, they will assess you on the OSCE station. So that is basically about the common selection examination. And I'm sure you don't know much about this close marking system. So in postgraduate exams, it's usually a close marking system. It's not like like when we were students, they will mark out of 100 how much you will get. It's not like that. So in the OSCEs, you will get this close marking system. It's like now, if you get 3, it's a pass. So if you get 4, it's a good pass. 5 is excellent pass. Borderline is 2. If you fail 1, I think you will fail the exam. So it's like, it's very, there is a very good note regarding this in the PGIM website. So you can go and refer to that. I'm not going to tell a lot about this close marking system. So after doing this exam, and when you become a trainee, so you can go into either ENT, eye, general surgery, or orthopedics. Out of 4, you can do whatever you like. And also sometimes it may change with the merit list. So if you are on the top of the list, you can take whatever you like your merit list in the internship. And then if you are at the bottom of the merit list, sometimes you might not get, sometimes orthopedic surgery or general surgery, something will be full and you won't be able to go. Right? And the merit list also comes with the attempts. So the first attempt, students will be in the top, then the second attempt, third attempt. Like that, I'm sure you know there are, I think, only 6 or 7 attempts you can maximally do in part 1 also. Then you are in the training for about 3.5 years, and you will sit for part 2 paper. So that will be either orthopedics and general surgery. So ENT, I will be having their own methods of going for doing the part 2 exam. When you pass part 2 exam, you have a maximum of you have to at least do 3 years of training. That can be that should be training in Sri Lanka, also training in a foreign country. So training in Sri Lanka is a must. Also, this foreign training is a must. And you also get a scholarship, a fully paid scholarship to do this foreign training. So before that, after doing part 2, you have to select what is the subspecialty you are doing if you are in the general surgery stream. So if you are in the general surgery stream, you can either go with general surgery with special interest. So if then you will become a general surgeon with special interest. It can be upper GI surgery, hepatobiliary surgery, lower GI surgery, vascular surgery, breast surgery, endocrine surgery, and trauma surgery. But in Sri Lanka, in the hospitals, you have a special interest, but you can't only do this surgery. So if a breast surgeon is there, that breast surgeon can't only do breast surgery in the government sector because we have a lot of workload. So you have to do casualties and you have to operate on those. And also, but you can have this special interest with breast surgery or any other surgery where you will like go for another scholarships, you will learn more about these things, right? So you will know in and out about that your particular special interest, and you will be very good in it also, unlike you are doing all the surgeries. So that is one option. The other option is to go to a subspecialty, like what I did. So I'm in the surgical oncology. So in these subspecialties, you won't get this general surgery, the workload is a bit less than the general surgery because you are now subspecialized in a separate field. So I'm doing only cancer surgery. I'm not doing hernia surgery or varicose vein. Those things I'm not doing. So there is surgical oncology, cardiothoracic surgery, gastroenterological surgery, pediatric surgery, plastic surgery, urological surgery, vascular surgery, neurosurgery, and thoracic surgery. So those are the subspecialties which, if you want, you can go into. So that's your wish, what you like. There's a lot of array of things that you can choose on what you will do in for the rest of your life. That is the most important thing. For the rest of your life, so you will be in this field. So let's see whether there are any questions. If you have any questions, please let me know about the surgical specialty regarding the exams. Right. So next we will go to the most important thing, work-life balance as a doctor. So why it is important, especially for doctors, why it is important to balance work and life? As doctors, I'm sure you will get to know, we have very long working hours, especially as house officers. You sometimes tend to work 24 hours per day if you are doing a casualty, right? So it's very, where there are a lot of, it's not easy to do long working hours. And there's a high stress situation, high demanding. Patients might die in critical, the patients will be in a very critical situation. So you have to manage those patients and their families, right? And also your team. So you are a main in the team. Because surgeons will come only for the ward rounds. They won't do ward rounds 3 times a day as physicians because they will be either in the theater or in the clinic, endoscopy. So they have a lot of other things also outside the ward to attend. So you will be the boss in the surgical ward. So all the patients will come with problems to you, not to the surgeon or the registrar, senior registrar or senior house officer. So that is why you are having a challenging work environment there. You have to balance the nurses also, the minor staff, and then you have to work in this unit. So let's see what are the advantages of optimum work-life balance, which is very important as doctors, especially as junior doctors. So we all do this. We are in this field for maybe for the rest of our life, maybe another 40 years, we will be working. Right? About 35 years, we will be working as a doctor in the government sector, if you are in the government sector, or more than that after retirement also. So personal happiness is the most important thing if you are doing your job. So if you are unhappy, especially in Sri Lanka with this, because since we are getting a much low salary compared to other countries, the happiness is the most important thing to work in Sri Lanka. Because, so I have worked in the United Kingdom for 2 years for postgraduate training. So there you can see, however much you get paid, sometimes you are not happy, right? So the personal happiness is the most important thing, which we have it in Sri Lanka. So you have to enjoy what you are doing. And also the healthy lifestyle. So you have to have a healthy lifestyle. I know doctors are the worst patients, if you know, because like they don't think about their health. They don't exercise. They don't eat healthy. So you will just go to the canteen and eat a lot of carbohydrates or a sugary drink, right? So we are not eating healthy food because we don't have much time. That's our excuse is. Anyway, so you can always have a healthy lifestyle. So I'm sure as an intern house officer, it may be a bit difficult if you are in a really heavy unit. But after internship, you will have enough and more time to do these exercises and do yoga, go join a gym, right? And also eating. So you can eat vegetables, fruits, less oily stuff, right? So those things you can do. So these personal happiness and the healthy lifestyle, ultimately your family will gain as well as your patients will gain. So you will have better patient care. So your mind is free. You are not under a lot of stress. So which will reduce your burnout and you will excel in your work, right? And you will overall have a very good job satisfaction. So those are the important things to balance your work and life. So let's see this. So I wanted to show this. You are killing yourself for a job that would replace you in a week if you drop dead. So that is the bitter truth. So that is the reality. So you have to take care of yourself. That is the very, very important message. So how to develop a work-life balance as a doctor? Okay, which is a difficult thing also. So you have to prioritize your responsibilities at work as well as at home. So at work, if you are having a lot of work, you should not write a discharge card of a patient who's planned to discharge tomorrow. So you have to prioritize your responsibilities. You have to take care of your critical patients, and you can later see a patient who came for a routine surgery. In another 2 days, for a hernia surgery, a patient has come. But that is not your priority. You have to check for that critical ill patient first. So you have to always prioritize. Right? And you can have a small notebook which you can write. Okay. And also you have to establish your boundaries, especially when at home, like if you are getting a free weekend. And then, so someone might come and ask whether you can do this for me this weekend, is it possible? So of course, you are a team member, you have to help, but not regularly. Regularly, one person is coming and wanting you to do that person's weekend. So that's not fair. So those things, you have to learn to say no, which is important thing. You have to learn to say no, for which you are not comfortable with. Okay. And then good time management. I'm sure as medical students also you have done it very well. Communicate with your consultant. If there's any problem, as Prof. Bhavanta also said, you have to communicate with your consultant. So he is the team leader in your surgical unit. So if there is any issue, you have to always communicate, because when it comes to tackling problems. So it is important to communicate also with your senior house officers and surgical registrar, senior registrar. So then, as I said earlier, take care of your physical and mental health. Mental health is also very important. So you have to foster a support network for that. You have to have good colleagues, good family members, good relatives. Always, if there is a problem, you should be able to openly talk about your problems, a workplace problem, a personal issue, anything. Right? So those are the things for good work and life balance. And also, you have to seek out professional development, like what I did the postgraduates. Right? So it is very important once you become like a senior house officer, to develop a professional subject which you like. So you have to really like this specialty which you do, because especially in Sri Lanka, after you become a consultant, you will be posted to very far away places. Like I'm in Kandy, my children are in Colombo, and my husband is in Hambantota. So you must be thinking, what a pathetic life I have. But actually not. So I tend to enjoy working. Also, I give 100% at work. And when I go home also, I give 100%. So what you do, you have to enjoy, otherwise it's not sustainable. Also, you have to cultivate hobbies. As a doctor, in whichever specialty, you have to cultivate hobbies like singing. Some doctors are very good singers, maybe professional singers. And painting, or what I do, I like baking or making cakes, right? Whatever you like, you have to have a hobby as a doctor, whatever, or hiking. So some doctors are going to far away places hiking. They enjoy, right? Traveling, doing a sport. You can, like, there are very good like badminton players, cricket players, right? Among doctors. So you have to cultivate hobbies. Also, you have to schedule a time for personal and family life, especially after I'm sure in the internship it's been difficult because it's a training. After that, you will be able to. And also, I have told about learning to say no, and you have to practice gratitude. So that is also a very important thing. You have to be happy about what you do for the patients and also for the family. So, like at the end, I also would like to stress on the fact that you are totally replaceable at work, but not at home. So you have to balance both to become a good doctor. Any questions? Yeah, doing gene and obs appointment in intern period is eligible to sit part 1. Yes, it is. You are eligible if you do gene and obs even to sit for part 1 surgery. But I think if you can get a post-intern surgical appointment, I think it would be better with this common selection examination. And because when I did my part 1, I was a ICU anesthesia IMO, because I thought I will learn anesthesia also for surgery. But now I don't think doing another subject, like another stream, is really important, because it is they will ask about surgical things. It is if you can get a intern appointment in surgery, it is good. It is easier for your exams, but also this gene and obs is no problem at all. what is the difference between MRCS and MD? So MD is this. MD is the exit qualification, right? So when you get a MD in surgery, you will be can practice as a surgeon with other requirements. MRCS is in the UK, in the United Kingdom. In the United Kingdom, it's an entry qualification. MRCS is an entry qualification where you will go into the stream. But if you have a degree, if you don't have a degree from the United Kingdom, even though you have MRCS, it is very difficult to get a number for to practice as a registrar. So if you, it is difficult to go into their training system just with MRCS. If you don't have a degree from in the United Kingdom. And MRCS is not valid in Sri Lanka for any, it's not taken as a specialist requirement. So if you like only, you can do MRCS, good to know, good to do thing, like we all do. Maybe we are surgeons, so we want to show that we can do MRCS, but it's a nice to have thing, not essential. So the next question is, to do medicine and gynae ops, I think it's 1 minute past the time. To do medicine and gynae ops for intern rather than conventional medicine and surgery, can you tell us why should to stick to medicine and surgery combo? Okay, so actually I also did medicine and surgery because I hated gynae and gyn and ops. So now you can do whatever you like, actually, whatever you prefer. So gyn and ops is also good, surgery is also good. But if you want to do surgery for postgraduates, I think better to do surgery. But both you can do, no problem at all. What is the significance of merit list in the selection exam? So in the merit list, it's like I told you, first attempt students will be on the top. They are also with the marks from, they will select 1, 2, 3, 4. So if you are in the top of the list, you can choose whatever what you like, the stream you like, also the surgeon you like. So some surgeons are a bit like they say they are a bit too strict and all, some like that. So some says that unity is not good, or the units are far away. So you are at the end of the list and you get teaching hospital Anuradhapura or teaching hospital Batiklo, where your family is in Colombo. So then as when you become a registrar, also there's a lot of work. You can't come every weekend home. So then it will be bit, so if it's better to have a better merit rank, but also it's not a huge problem. If someone is planning to do gyn and ops for postgraduate, is compulsory to do gyn and ops in, I'm sorry, I don't know that gyn and ops, but you can always go to this prospectus in PGIM website and see what are their requirements for gyn and ops. Okay, they are telling you can take more time. Is it the MBBS merit list or merit rank after MD selection exam? Okay, so MBBS merit list is for your internship. After that, when you become a registrar, it is the MD selection exam merit list. And after that, when you do part 2 for senior registrar, that is the list, that merit list is, there's a separate merit list for part 2. But after you become a surgeon, also there is a merit list according to your seniority. So now think, there are 2 surgeons. Both are from parallel batches, like your internship batch. Both are from the same internship batch. both did the part 1 in the same exam, they got through. Part 2 also the same exam. You don't mind the merit list in part 1 and 2. Same exam you have got through both exams, and then your marks will be the same. So as a surgeon also we get marks for our transfers. So marks will be the same. Then they will go to this merit list in the final MBBS, and the better merit list person will be in the top of the list than the other person. So that is the important thing about the MBBS merit list. Right. Anything else you want to know? I think, okay then. Thank you very much for listening.
Right. Thank you, madam, for that lecture. So next up is Consent and Professionalism by Dr. Indra Fernando. We'll just log in.
Hello, good afternoon. Can I be heard?
Yes, I can see. Yes, it's moving.
Yeah, thank you very much. So I am Dr. Jayendra Fernando. I'm a consultant general surgeon and also past president of College of Surgeons. So dear doctors, I'm going to talk a little bit about professionalism and some aspects. And I'm very thankful to actually Professor Bhavanta Gamage and Dr. Minoli Joseph, who have already introduced some aspects of that topic. So professionalism is a very wide, big topic, and we are just going to touch a few things which I think are very relevant to you young doctors who are going to start internship. So by professional, the word professionalism, we mean a lot of things, and it includes non-technical skills, patient safety and quality. And in fact, in your pre-intern program, this educational program, the Ministry of Health has dedicated a whole day, that is tomorrow, for quality and safety. And however, the College of Surgeons thought this topic is very important and have very kindly allocated me some time today. So with the kind permission of the Ministry of Health, I'm going to make this presentation. It's actually scheduled for tomorrow, but we are doing it early. So in this, there are two things, two lines I have put up on the screen: doctor-patient relationship and doctor-team relationship. They both have a lot in common. The doctor-patient relationship centers around consent, safety, and communication. And the doctor-team relationship centers around team dynamics, safety, and communication. So all these things are overlapping and interconnected. So if you do one, it helps the other, and everything together is what makes you a really good professional. So let's take one at a time. Consent is the key to the doctor-patient relationship. So without consent, there cannot be any doctor-patient relationship. So as you know, consent is either implied or expressed. And the moment the patient comes to you, there is a certain amount of implied consent. So you start off from there and then take it up to the more details. So in 2021, the Ministry of Health actually issued this circular, which made it mandatory that consent has to be, there's a minimum standard of consent that is expected for all surgeries, starting with the major and intermediate surgeries. And that consent has to be documented in a specific form, which is produced by the Ministry of Health and is available in the hospitals. It has a front page and the back page. So this is part of the front page. It basically has the biographical details of the team that is going to do the surgery, and some details of the surgery itself. And its behind side has the patient who is identified by the signature and the NIC number, and any other details, like if there's a guardian or a witness, what is the relationship between the witness and the patient, and few details like that, which are very important. So I think when you go to work, when you take this consent form, have a look at it. All these boxes are very important. Now, you need to be aware of the essential part of the consenting process. Consenting is not a single event. It's not a one-off, one signature. It's a long story. It's a continuing thing. And you must understand that the consent can change. So a given consent can be withdrawn. A given consent can be changed by the patient. So it's a story that unfolds. So there are a few elements to consenting. One is, the most important thing is that the patient should have capacity for consenting. He should have an intellectual and healthy ability to consent. Now, in the Sri Lankan law, which is common to most countries, it is assumed that all adults, in our case over 18, have the ability to consent. So if you think that the patient does not have capacity to consent, it's a very serious thing, which as a house officer, you should discuss with your senior colleagues and your consultant and find solid reasons. Otherwise, the law will assume that every adult has a capacity for consenting. There are some instances where the capacity is lost. I will come to that in the next slide. So this consenting is called informed consent. So informed consent means that you have to provide adequate amount of information. So how much information to give? Also, I will mention some concepts few minutes later. So information has to be given, explanations have to be given. What is the surgery you are going to do? What your team is going to do? What is the expected outcome? What are the possible complications? What will happen? All that has to be explained to the patient. Then there is no case of getting 50% consent. It has to be a total bilateral agreement. Patient and the team has to agree that we are going to do the surgery. So the patient has to agree and has to agree with his free will. There should not be any inducement or forcing the patient to give consent and so on. They have to voluntarily give consent. Otherwise, that consent is not valid. Giving consent is not enough unless it is documented. It has to be done in a proper form. And according to the Health Minister circular, consenting can be done only on the prescribed form. So a signature on a bedhead ticket or a signature on a small piece of paper is not valid consent. Dear doctors, please remember this. This is a legal requirement. So any hospital doing anything less than that will not be supported legally. It's very important. And these forms are available at the ministry, the MSD, and it is the function of all hospitals to get this. Then, of course, consenting is finally completed only when the patient places the signature. And if the surgery is very complicated and there's a possibility of bad outcome, it is always good to have a witness. And the witness's name and relationship must be documented, that the patient actually consented for this high-risk surgery on his own free will. Otherwise, the law will not support the doctors that consent has been taken. So, as I said, all of you doctors know that it's not always that the patient has capacity for consenting. There are emergencies where there is no time to get informed consent or the patient is not in a fit state. Then there are minors, that is the children below 18 years. In the case of minors, if they are old enough, if they are in their late teens, their views must be considered when consenting. So if a 16-year-old does not actually want to have surgery done, that view must be taken into account and every effort must be made to convince that child that surgery is beneficial. For minors, if the obvious parents are not there, then the consent can be given only by a legal guardian. So a neighbor or a relative cannot just give consent. If such a person has to give consent, the surgical team must be very careful that they are actually giving it some responsibility. Obviously, unconscious patients cannot give consent. So every effort must be made to get consent from the next of kin. Mentally unsound patients, it's another problem. Intoxicated patients, it's always wait. It's good to wait till the intoxication wears off. But if it is an emergency, then some action has to be taken. Then there are some instances where a second procedure is required during a surgery. For example, say a patient undergoes appendicectomy and then it is discovered that the patient actually has a carcinoma in the ceca. So a second procedure is needed. Or a patient undergoes a cesarean section and there is uncontrolled bleeding where a hysterectomy has to be done. So in such cases, if it is, there are only two options. One is you can get the patient out of anesthesia, get consent and then do the surgery. Sometimes it's obviously not practical. In that case, consent must be obtained from next of kin and every effort must be done that all the information is shared with friends and family and proper consent is taken at that time. So dear doctors, please remember that you're the house officer, you're the most junior person in the team. In these instances where consent is not obvious, you need to ask your consultant or inform consultant that there's a problem with consenting and get the best advice how to proceed. So don't get into a complicated situation where you get improper consent and that becomes a problem. So like the consent form, the Ministry of Health has some other documents which have been done together with the surgeons, which actually improve the safety of our patients. Now, the WHO surgical safety checklist is one of them. I'm sure you're aware of this. If you're not aware, well, this is the time to start being aware of it. This checklist has 3 parts called the sign-in, time-out, and sign-out. So the sign-in is done when the patient is brought to the theatre unit. It's usually done by the nurses or nurses and the anesthetist together. The timeout is done at the time just before the skin incision is made, and it's done together by the nursing staff, anesthetist, and the surgeon. So it is the responsibility of the surgeon to do this timeout before he makes the incision. And sign out is done at the end of the surgery. So dear doctors, please be aware that this is a very important facet of surgical process. And you will also have your part in this. And particularly if you're interested in surgery and in studying to become a surgeon, then this is a very key thing. It's not only this document, the Ministry of Health is actually introducing a new post-operative observation chart, which is a very attractive color-coded chart, which when used properly, will actually trigger a message from the nurses to the doctors and the surgeons that something is really wrong with the patient. As you know, you already know that in the post-operative observation, you look for pulse, blood pressure, respiration, any evidence of bleeding at the wound site or internal bleeding, level of consciousness and all that. So all those key observations are documented on this form at a given time. And then it is easy to visually know that something is wrong. But it is very important for you to remember these documents are there to help you, but it is not the final say. Final say is your clinical judgment. So what you have learned in the last 5 years will come into play at a time of emergency. It's not only these documents and it's not only these forms, it's your clinical judgment. So everything to put together is what makes the patient very safe. So we go a little bit different, and this is all a very important part of being a really good professional. It's communication. Now, not only in Sri Lanka, world over, when problems come, problems will definitely come in hospitals, right? Our job is where patients come with problems. Our job is to solve them. But in that, there are nothing, sometimes it doesn't go perfect. Various things happen. Whatever good you do, sometimes things do happen. And when things do happen, it's seen as a bad thing only when the communication is bad. So communication simply is, with whom do you communicate? You have to communicate with the patients, and not only patients, with the patient's loved ones, that is friends and family of the patient. Very important that you communicate with them. And then of course, you communicate with all your team members. So starting with your other doctors, the consultants, the nursing staff, other technicians, technical staff who help you, like the ECG technicians, radiology technicians, blood technicians, and so on. So you have to communicate with all of them. And communication is a very, very important part of being a professional. So if you can communicate, then a lot of your problems are solved and half your work is done. Because you'll find that if you communicate, you get more help and more job satisfaction, and you enjoy your job. So when you communicate, well, with patients and loved ones, you have to communicate pre-op, that is at the time of admission and in the consenting process. So communication is not a one-off thing. Just like consenting, it's a process, it's a continuing process. You keep communicating and communicating in both directions. You listen and you talk. Listen, talk, it goes continuous. So you have to communicate at the time of admission, when you get consent. And then just after surgery, you have to try to inform the patient and the family what has happened. Has the surgery gone out well? Are there any issues? Are there any problems? What is the likely duration of stay and all that? I think Professor Bhavanta Gamage also touched on this. It's very important. Up to the point of discharge, you have to communicate. And then, of course, I have not written it here, but in the follow-up visit, when they come to the clinic, the process goes on. So till the patient is finally discharged from the surgical process, the clinic, you have to communicate. And when do you communicate with the team? Well, all the time, 24/7, you have to communicate. You know, it's upwards, downwards, sideways, everywhere. So your communication has to go in the appropriate way, at the appropriate time, all the time. So very important, you all know this thing, that communication, the spoken word is just a part of it. Your voice, tone is important, and more important than that, body language. So dear doctors, when you talk to your consultant, please look at his or her eyes and the face and talk. If you look the other way, your consultant might get the wrong message. Either you're worried about something else, or you don't know your work, or you're trying to tell something else. Very confusing. So please look in the face and express yourself. And try to learn nice words to start talking. Very important. So generally, it's good to have a format. When you talk, either physically, face-to-face, or on the phone, make it easy. Don't go on and on. So your communication has to be structured. So first thing is identify yourself, unless of course it is obvious that the person you're talking to knows who you are. If it's a patient and the family, you have to identify yourself as Dr. So-and-so or the house officer of a particular ward. Otherwise, they will not know whom they are talking to. Start with a little greeting, whatever is appropriate, whatever greeting you like, and then mention why you are talking. If you are talking to a consultant in the night, say that, quickly get to the point, right? Why you are talking, and then deal with the subject. It has to be precise and it has to be concise. So you have to deal with the subject. And next line is very important. Do not hint and hope. Be very specific. If you hint and hope that the person understands, message may not reach there. And sometimes the wrong message may get there. So please do not hint and hope and expect. Just deal with the subject, say what you want to say. And one thing that I used to do, and I still do, if I'm communicating something important, like a bad patient, is to make a note before what you want to say over a telephone, and make a note after. Write down all the instructions you have got. That way, in a single telephone call, you are not going to miss the important things. Otherwise, what happens is, under stress, we forget few things, and that might be the most important thing. So even if it's on the phone or face-to-face communication, it's always good to write what you want to discuss or what you want to communicate on a little notebook. Discuss and then write down all the instructions and the outcome of the communication. Very important. These little things actually go a long way. And you'll find that your internship, if you do it nicely, is very enjoyable, and you will be able to balance your work with your personal life and really have a good time. So this is not an easy thing to discuss. Information and how much you disclose, how much to give, what to give. Like for example, if it's a surgery is being planned, how much to talk about complications? Well, you don't want to scare away the patient. That's not the idea. You don't want to tell that, death is always a possibility after surgery. No, that's not the point. So there are two words that are in use in international literature. That is called the prudent doctor and the prudent patient. Well, I'm just only going to tell you the meaning of these words. A prudent doctor is a doctor who will ask and tell information what a normal doctor would do, what a usual, dutiful doctor would do. He's a prudent doctor. So generally, you as a doctor are expected to be a prudent doctor who will generally give information and disclose what a usual doctor will do. And a prudent patient is the patient who will ask the questions that normally patients ask. However, there are patients who will either not ask anything and who will actually suffer because they have not asked, or will ask more than what they should ask. So either way, you must actually understand the patient's needs and the patient's background and provide them with the information that is appropriate to those. So this is a very complex thing. There is no perfect solution. There is no rules and regulations because it differs from country to country, and in our country also it is not properly defined. So you have, it's an art and a talent that you will grow and that you will cultivate. But these two words are important. You might like to read up more about it. Who is a prudent doctor and who is a prudent patient? And what is information that has to be given and how much you disclose? So as doctors, every day is not a nice day. Sometimes we have to give bad things happen and we have to give bad news and sad news. And when you have to do that as a doctor, first thing is, it's very hard. Sometimes it's really hard. Even for a mature, experienced doctor, sometimes this can be challenging. So there are a few things you can start doing. First, if you have to give bad news, you can mention positives. I mean, in fun, we say there is good news and bad news. So first try to give the good news, the positives. Then take it gradually. As a young doctor, you must be very careful that you go stepwise, little bit at a time. Don't put everything, all the bad news on the table at once. Your patient is not going to be happy and not going to be impressed. So do it stepwise. Then, of course, legally, you are not supposed to hold anything back because it's patient's information belongs to the patient. It does not belong to you. However much you think you're a good doctor and so on, that information, the owner of the health issue is the patient. Owner of the information is actually the patient. So you cannot hold anything back. You have to deliver it step by step. Patient is your responsibility and delivering the information is also your responsibility. Have an understanding of the patient's feeling. That is basically what is called empathy. You have to empathize with the patient. And as a junior doctor, be very guarded. When you're giving prognosis, don't go to extremes. Don't give extremely bad prognosis. Don't give extremely good prognosis. Be guarded, be balanced. And if you're really unsure that you should give this information, ask your consultant. Maybe your consultant with his or her experience be able to deliver the same message gradually, step by step, and make it a little palatable, or you might be advised how to deliver it. So be guarded, and when things go wrong, don't blame anybody, because the patient will take that and make it into a very big issue. So even if you feel that somebody, either your colleague or a nurse or even your consultant is to be blamed, even if you feel like that, don't express it. Just keep it in yourself, because you might be right or you might be wrong. So you don't want to give a wrong idea to the patient. It's okay for you to discuss it with your colleagues, trusted colleagues, but don't give it to the patient. So don't blame anybody. So these are very important things. Be guarded, look after yourself, look after the patient, and look after information. It's a very, very responsible thing to do. And not every patient is easy. So there are times when the patient can be difficult. They can be scolding you. They can be giving you a torrid time. They can be bullying you either overtly or in a subtle way. They can tell bad things to you. So what do? Well, these are 3 things I learned from a workshop. INR, isolate, negotiate, refer. So isolate is you try to isolate if there are a lot of patients' family around them shouting at you and trying to be difficult. You isolate the patient away from a big crowd. Because sometimes when the patient is isolated, sometimes they can calm down. Then you negotiate. You talk to them very nicely. You don't shout at them. If the patient is shouting, you also don't shout. So you negotiate. You have to, your social skills, everything you got, you have to put it at that time. You negotiate with the patient. You try to get the patient to understand that it's a problem, that you're doing the best, even if the outcome is not perfect. Certain things you can show positives. You try to negotiate. When you negotiate, if the patient calms down and is understanding and you come to agreement and a settlement, that's fine. If you cannot, you refer to somebody above you. So you refer to a senior colleague or a consultant. So this is something you must always remember. If you get a difficult patient, these are the 3 things to do: isolate, negotiate, and refer. Don't go to fight with the patient. If you think you cannot handle the situation, you have to refer to somebody else. Please remember, it's very important. And always have the professional behavior. If a patient is bad, you don't go bad. You are the doctor. You have to behave good. And you have to give somebody else the opportunity or something. So this is where this topic called emotional intelligence comes in. Now, intellectual intelligence, you all know, you are supposed to be intellectually intelligent. That's how you got through exams, studied. You know a lot of facts. That's all part of your intellectual intelligence. But from now onwards, your success is dependent very much on emotional intelligence. And it is the key thing for leadership. Now, all doctors are leaders in a certain way. You're a leader when it comes to patient handling because you're leading the patient into a solution. You're leading a team of others, including nurses and other team members. So what is this thing called emotional intelligence? Very important thing. We senior people are learning a lot about emotional intelligence. So emotional intelligence, the aspects are recognition of emotions of ourselves and the others. Emotions in the sense that, am I feeling very pleasant or unpleasant at this time? Is my level of energy high or low? And what is it in the person I'm dealing with? So the patient's pleasantness may be not that good. The patient is sick or is after the surgery or has got bad news and so on. So you need to recognize the emotions of myself and the others. And then, of course, we have to regulate our emotions. And we have to try to match my emotion with the patient's emotion. If the patient is really in a bad mood, I can't be singing and dancing. I can't be crying either. So I have to know how to regulate and get this thing. So I need to show a little pleasant face, try to pull the patient from that bad mood into a better mood if I can. But it has to be done in an appropriate way. And then it is always good to be open about emotions. I think as we mature, we realize this, that hiding emotions is not going to help. So emotional intelligence is a big topic. We cannot finish it in a couple of minutes, but I have given you some ideas, and those who are interested, and go and watch some YouTube videos and learn a bit more. Certainly, definitely it's going to help you. And if you have ambition of achieving senior positions in our service, this is a must. And coming to the end of my talk is about team dynamics. Now, you're not an individual, you're another member of the team. And your work and the pleasure and the joy you get out of being an intern doctor is totally dependent, not only on the patient, but on the team. So if you have a good co-house officer, if you have good nurses, if you have a good consultant, you're going to enjoy. But of course, your joy is dependent on how you interact with your team also. How you receive supervision. Do you happily receive supervision from your consultant? That way, that's what I was telling you earlier. Your communication, your body language is very important to receive that supervision from your consultant. In the sense that there is a thing called leadership, there is also something called followership. So in that followership is this ability to receive supervision. And then giving feedback. Communication is not one way, it's both ways. So giving feedback to your consultant, giving feedback to the patient, giving feedback to the nurses, very important. You need to give feedback. If your nurses are good, you have to give them feedback. I think in one of the previous lectures, we heard the ability to be gratitude, ability to feel gratitude is something that you need to develop. If you feel gratitude, express it. It's one way you get a lot of help from everybody else. And asking for help. We are not alone in this. Ask for help when you can. Don't of course be a crybaby asking for help all the time. That's not what I mean. You need to develop the art of knowing exactly when to ask for help, knowing exactly when you are in trouble. So ask for help from anybody. You can ask for help from nurses, from your senior doctors, from consultants. Ask for help and they will help you. I still remember when I started my internship, it was in my first week. During the night, there was a stab injury. And after I clerked the patient in the night, it was about 2 in the morning. I was not sure whether I should wake my consultant and tell him because the patient was stable. Probably the stab had not gone too deep or did not. And I was really not sure. Luckily, there was a nurse, I still remember. She basically told me to go and sleep and that she will do the observation and call me if there's anything to worry about. Actually, I slept the rest of the night and came back in the morning. The patient was fine. But the help that you get from different places sometimes can be amazing. But you have to ask for help in some way. Either you have to express it or you have to just show that you need help and help will come. And of course, you're working in a team. There's always called volunteering and sharing. So if your colleague is very busy and if you're free, don't think that as an advantage. Go and volunteer and share the work of your colleague. And that way it'll come back to you. I actually had an opportunity as a junior doctor where I, in fact, volunteered to one of my colleagues to do appendicectomy, not a very big thing. I was a trainee at that time. I volunteered because I was free and that my colleague was very busy. And in fact, this volunteering comment was overheard by a very senior consultant. 6 months later, I actually got a letter of recommendation. And in that letter, this act was mentioned. I didn't think a big deal about it, but I think now it's a really good thing. If you have free time or if you have time, volunteer to share the work with colleagues. That way, it's very enjoyable. Very important to delegate work. Don't keep everything on your shoulders. You need to have that ability how to delegate. And looking after your nurses is very important. And respect everybody. Not only in your mind, you have to feel that respect to others. It has to come from within you. Respect your nurses, respect all the staff. And as you go in life, you'll find that you are a very respected person. But that does not happen naturally. You have to feel that respect for everybody around you. Respect all the hard work that others are putting in to look after your patients. So this team dynamics, this slide is very important. I hope you can remember some of these things. And then finally, I have said a lot of things, and remember, we are doing everything for the safety of our patients. And the safety is totally dependent on communication and team dynamics. So dear doctors, I hope you learned something from the few words I have spoken. I hope you enjoy your internship. And if there are any questions, I would be happy to answer, because I'm aware that before your next presentation, you'll have a little break. And so you have a little time. If you want to ask me anything about consent, any aspects of professionalism, please go ahead and ask in the chat. Yeah, I cannot see any questions. So just want to thank the Ministry of Health for organizing this and giving us, yeah, there's a comment. Thank you for sharing wisdom and experience. It was motivating and much needed. The College of Surgeons has some programs on professionalism. We do workshops. So we have opened it to all the doctors, so we'll share whenever the next workshop that will come. We have already planned few workshops for next year. We'll let all the doctors know about it, that you can join. Thank you for that comment. Well, thank you, Ministry of Health, for organizing and giving us surgeons time to talk. And of course, all the support from my college office. So thank you very much. Good luck to all of you. Bye.
Thank you very much, sir, for that comprehensive lecture and giving guidance for the interns. So we are coming to the next lecture by Dr. Nalaka Gunawansa, diabetic foot followed by vascular injuries. I think sir will join shortly.
හරියටම ගාන කියන්නකෝ මිස් එහෙම බලන්න.
Hello.
Yes, sir. We can start. I've given the introduction.
Hello, can you hear me?
Yes, sir. Can hear you. Can hear, sir.
Hello.
Sir,
Hello.
can hear, sir. You can
All
start.
right, okay. No, just getting the technical issues sorted out. Sorry, I'm at the consultant lounge and the connections are not that great. You can hear me now, right?
Yes, sir. We can hear you loud.
Right, okay. Just give me a second. I'm sharing my screen. Just tell me whether you see this.
Okay, sir. It's coming up. Yeah, it's up. Sir, can you make it full screen?
Yeah. Okay, done. Can you see?
Yes. Can we move a few slides and see?
Yes.
Yeah, moving, sir. We can start. Yes.
All right. So first of all, sorry for the delay. I'm just in between work and just going through a very unstable internet connection. But anyway, if there is any issue, let me know. I hope you can hear me. And I'll keep it very brief and simple since we are late already. So first talk is on vascular trauma, which I believe is a very important topic for pre-interns, obviously, and interns as well, going ahead. Because especially regardless of where you are working, especially if you are working in a peripheral hospital, even in an accident service or even in the surgical casualty, vascular trauma is a very common presentation that you get in casualty wards and casualty surgical wards especially. So I'll just run through a little bit of introduction. So basically what we mean by vascular trauma and what is the real importance of vascular trauma. Simply because especially two things, if you really put it bluntly, any kind of vascular trauma, if unattended or uncorrected, can lead to either death of the patient or death of a limb. For example, an unattended vascular trauma with continuous bleeding, continuous hemorrhage can obviously lead to hemorrhagic shock and death. On the other hand, in a limb, let's say you have a lower limb or upper limb injury, and the arterial supply is damaged and the vascular compromise is there without any blood supply. Even if the patient doesn't bleed to death, the lack of blood supply to the distal part of the organ, distal part of the limb, will cause ischemia, and after a matter of roughly 6 hours, there will be muscle death leading to limb loss and amputation. So that's the importance of knowing and identifying vascular trauma. So when you talk about vascular trauma, very broadly, we categorize it into three ways, which is blunt tissue trauma, penetrating trauma, and iatrogenic trauma. Now, blunt force trauma is without actual penetration of the skin, where you can get crush injuries. Common examples are motor traffic accidents, people who fall from a height. Now, when you say fall from a height, you will think about a fracture. It was not necessarily a fracture. Now imagine a person who's falling from the roof to the floor. Yes, they may have fracture, but at the same time, those fractures will cause disruption to the adjacent blood vessels, adjacent arteries. So if you have a tibial fracture or a femur fracture or tibial plateau fracture, or even for that matter, in the upper limb, elbow fracture or elbow dislocation, that dislocation and the fracture force will cause damage to the adjoining brachial artery or popliteal artery or femoral artery, leading to internal hemorrhage, distal ischemia, and catastrophic complications. Penetrating trauma is very easy to understand. That's like a stab injury, gunshot injury. So anything that penetrates the area where blood vessels are, the penetrating trauma can cause through and through injury to the blood vessels, causing internal hemorrhage and distal ischemia. Now, iatrogenic causes are different. Iatrogenic causes generally mean complication that you get or vascular trauma that you get secondary to some kind of medical intervention. More often than not, or in almost all the cases, it is inadvertent. For example, you might have a person who's in chronic kidney failure, who's requiring dialysis, and they put a central venous line for dialysis access. During the attempt to put the central venous line, there may be an inadvertent damage to the artery nearby, because arteries and veins are adjacent to one another, just about 1 centimeter separating them. So penetrating the vein for venous access, you might damage the adjacent artery, causing arterial damage. Sometimes there can be intra-arterial injections. For example, when you give, these are rare, don't get scared, these are rare, but can happen. For example, when you give intravenous fluids, sometimes mistakenly you might put the catheter or the cannula into an artery and give the injection intra-arterial, and those are iatrogenic, inadvertent. Inadvertent means not intentional, unintentional results of medical intervention. Again, if you categorize it, you can also categorize the type of vessel involved. So see, when you say vascular trauma, you're thinking about arteries and veins, and you have the arterial injury, which is very important and quite dangerous. You have venous injuries, and sometimes you get mixed injuries. So arterial injury is very easy to understand. You have your main artery, brachial, femoral, popliteal artery, as we discussed earlier. If a damage to one of those main arteries occurs, there is potential for significant hemorrhage, especially in the thigh and the knee area, because intramuscularly, a lot of blood can leak out, a lot of blood can collect, and before you know it, patient would have lost 2.5 liters, 3 liters of blood into those compartments, and the patient may go into hemorrhagic shock without even actual obvious injury outside. Venous injuries are less complicated and much easier to handle, because venous blood flow, as you know, is low pressure system compared to the arterial system. So even if there is an injury, majority of the time, not all the time, but majority of the time, they spontaneously settle down, because the venous pressure is not so high. Therefore, the low pressure system doesn't allow for continuous bleeding. Generally, with elevation of a limb or keeping direct pressure, the venous injuries generally settle down and you don't need to do anything. But quite often what you get is actually mixed type of injuries, where you have the arterial and venous both. So a good example is if you have a gunshot injury to your popliteal fossa, knee area, or if you have a severe dislocation of your knee, you can get damage to the adjoining artery and as well as the adjoining vein. So you have mixed injuries where both the main blood vessels are affected. So how do you diagnose? Again, very important, because now, unlike most other things, you don't have a definite blood test or something for you to identify a vascular injury. So vascular injury is purely clinical diagnosis. That means it's what you take the history, what you examine for, and what you find. On that basis only you diagnose vascular injury, not by doing a blood test and seeing that the hemoglobin is low. By that time, it's too late. So in diagnosing arterial injury especially, you have what are called hard signs and soft signs, right? And the importance of knowing this is, as I said, unlike the venous injuries, which more or less spontaneously settle down, arterial injuries do not settle down. They bleed a lot. And even if the bleeding eventually settles down with a hematoma, the fact that the artery is disrupted means that distal to that disruption, there is no blood flow. For example, let's say you have a fall from a height and you break your femur, and because the femur is broken, your adjoining femoral artery is damaged, that means there will be a hematoma collecting in the thigh area where the fracture is. But more importantly and more dangerous is that beyond or distal to that fracture, distal to that hematoma, because the artery is now disrupted, no blood flow occurs. So there is no blood flow beyond the femur, which means your lower thigh and the calf area muscles become ischemic. And now it becomes a race against the clock, because muscle ischemia means within about 4, 6, maximum 7 hours, the muscles start dying. And when the muscles are dead, they become non-viable and leading to amputation eventually in that particular limb. So that is very critical, especially because, for example, when these patients come to a peripheral hospital, rural hospital, to identify them immediately after an injury, to check and identify that there is a vascular injury, there is a potential arterial injury, and communicate with your seniors, and then to transfer them to a definitive care facility nearby, the closest main hospital or Colombo. You need to act quickly. You can't just say, all right, I'll check it tomorrow morning and send tomorrow morning. It won't stay till tomorrow morning. Either the patient will die or the limb will die. So you need to attend to it immediately and get things organized, get an ambulance organized, transfer, and ideally the patient should be reaching a definitive care facility where a vascular surgeon is, ideally within 6 hours, so that the limb can be saved. So that's why it's very important for clinical diagnosis. So how do you do this clinical diagnosis? So generally, there is a categorization called hard signs and soft signs. Hard signs means signs which, if present, invariably tell you that there is a more than 95% chance of an arterial injury. Okay. So these, if I go one by one, first thing is pulsatile bleeding. So if there is a trauma, if the patient is brought after a trauma, after an accident, or after a knife injury or stab injury or whatever, and there is visible pulsatile bleeding from an artery, you obviously know there's an arterial injury. In the next slide, again, very important, the 6 P's, which means that there is evidence of ischemia, evidence of lack of blood flow distal to the area of injury, which will tell you that there is not enough blood coming, not enough oxygenated blood coming, which means there is ischemia and possible arterial injury. So what these 6 P's are, I will show you in the next slide. Then a palpable thrill. That means if there is a big injury and there is a hematoma, when you keep your hand, when you keep your palm, if you feel a thrill, that means there is persistent flow, persistent leaking. That tells you there's an arterial injury. Then you can keep your stethoscope on that, and you might feel a bruit. You keep the stethoscope on the hematoma, you might feel a bruit. You might hear a sound of kind of sound. That means there's an audible bruit. That means there is arterial bleeding. Then hematoma. So hematoma is the swelling, localized swelling. You have a patient who has a blunt trauma, no obvious injury, no pulsatile bleeding, nothing abnormal apart from a local hematoma of, let's say, 4 by 6 centimeters. You think, all right, okay, small hematoma, this will settle down. You keep the patient and you finish the blood round and come back in 1 hour. Now it's double the size, much bigger than earlier. An expanding hematoma again tells you, for expansion of such a hematoma, there has to be ongoing arterial bleeding. So these are the hard signs. So in the presence of these hard signs, obviously you know that there is an arterial injury which needs to be attended to. Then there are other little signs, cause of signs which are not that relevant, but again gives you the suspicion that there could be something specific, something, some injury. I won't go in detail about the signs because I think anyway you're unlikely to remember all that. But I'll be very happy if you can remember the hard signs, the pulsatile bleeding, the evidence of ischemia distal to the injury, a palpable thrill, an audible expansive or expanding hematoma. If these are there, 95% chance that there is a definite major arterial injury. That's a pure clinical diagnosis. Talk to your seniors, get the patient attended to immediately. So what are these 6 P's? Yeah, so the 6 P's, as I said, is a part of a component of arterial injury where when the artery is affected, distal to that injury site, there are certain symptoms and signs that occur. First one is pain. So obviously, when there is an arterial injury and there is no blood flow distally, patient will have pain. Pain not at the injury site, pain distal to that. For example, the fracture or the penetrating injury may be in the thigh, but the patient will complain of severe pain in the foot, not the actual injury site. Why is there pain in the foot? Because the artery is damaged at the fracture site or artery is damaged at the stab injury site in the thigh, and distally there is no blood flow, and therefore the muscles are ischemic, and now you get ischemic pain in the foot, ischemic pain in the leg. Just like you get a heart attack due to blockage of a blood vessel, coronary blood vessel, now you get ischemic pain in the distal part of the foot. So that pain becomes very important, pain distal to the injury site. Then you have paresthesia. Paresthesia is lack of sensation or reduced sensation in the area distal to the injury. That again due to inadequate function of the nerves secondary to ischemia. Third P is the pulselessness. So obviously you check the distal pulse. So there is a patient who has a stab injury to the thigh. You check the distal pulses on that leg, dorsalis, pedis, and posterior tibial pulse. Pulses are absent. You can't feel pulse. So in the presence of absent pulses in that leg and an injury proximal to that, you obviously know, right, the artery must be disrupted with this injury. Fourth P is pallor. So compared to the other limbs, this limb is now pale, white in color. Why? Again, lack of blood flow. The fifth P is paralysis due to muscle death. Muscle ischemia means muscles can't function. So now patient, you ask them to move, they can move the other limbs, they can move the other foot toes, but this affected foot, he can't move the toes. The toes are paralyzed. The last one is called prostration, which means basically performance, the patient's performance index. So patient can't perform normal function. So that again boils down to inadequate nerve supply, inadequate nerve function, inadequate muscle function, all that. So if you have going back to this example that I kept talking about, if you have this patient who has been brought to your ICU or brought to your emergency unit or ETU or your casualty surgical ward after an injury, and distal to that site of injury, there is lack of palpable pulse or pulses are absent. There's severe pain distal to that site of injury. That particular area looks paler compared to the rest of the body. There is paresthesia. There is muscle weakness in that area. Then you have all the components to tell you that this limb is now very, very critically injured with lack of blood flow, lack of arterial blood flow. So the lack of oxygenated blood flow coming from the arteries, that is the ischemia, and that's a definite clinical diagnosis. Once you are definitely diagnosed clinically, these are done not in the rural hospital or regional hospitals. Once the patient comes to a teaching hospital or wherever there is a vascular surgeon or vascular or a general surgeon who can do vascular surgery, when the patient comes to a main center, they might go beyond the clinical diagnosis and do certain investigations like image, find out exactly what's going on and where the injury is. So for that, you can do angiography, CT angiogram, digital substruction angiogram, various investigations to find out the exact anatomy of the injury. Then what are the treatment options? So when you go for treatment, again, the treatment, very important. You need to act fast, especially in the arterial injury. As I said, it's a race against the clock. You need to repair this fast and reestablish blood flow soon in order to, one, minimize the bleeding, two, to restore the blood flow and prevent ischemic muscle death. So surgical repair will be either with an end-to-end repair of the artery or with a vein graft. Sometimes, very rarely, we can use endovascular techniques to minimize the bleeding by getting an interventional radiologist to inject various things and prevent bleeding. And sometimes, very, very rarely, we can do conservative management. So conservative management comes only in selected instances. For example, majority of venous injuries, you can do conservative management. So going back to the same example we told you earlier, let's say the patient comes with a stab injury to the thigh. You check the patient, distal pulses are palpable. No pain distally in the foot. Only pain is there in the injury site. Muscle paralysis not there. No paresthesia. So the distal foot is not ischemic. Especially most important, the pulses are palpable, equal to the opposite side, which means clinically, you know, right, arteries can't be affected. But there's a hematoma. If there's a hematoma, and there is, especially if the hematoma is stable and not expanding, then you know it's a stable hematoma. Distal pulses are palpable, which means it is unlikely to be an arterial injury, which means most likely it's a venous injury. If that is the case, you can more often than not conservatively manage, observe, and these things settle down. So that is conservative management. The last bit about recovery, once you do a vascular injury, identification and direct repair, there is obviously a lot of rehabilitation that has to happen, because these are high velocity trauma, these are big injuries, these are not just a simple cut and scrape, these are big stab injuries, gunshot wounds, major trauma after vascular accidents, major trauma after traffic accidents. So lots of soft tissue injury, lots of bone injury, lots of nerve injury, lots of vascular injury. So even after the vascular injury is identified and repaired, you save the leg, but to get them back to their normal pre-accident function, you need rehabilitation, physiotherapy, pain relief, and lots of other things. So that comes with rehabilitation. Lastly, about prevention. So you as a medical professional, your job is not complete if you don't think about secondary prevention in these patients. So obvious things like avoiding risk behavior. If it's after road traffic accident, things like asking them to wear seat belts, taking protective mechanisms, those are your things that you can do to prevent or minimize further injury in the future. So in summary, vascular injuries can be life or limb threatening, especially if it is arterial injury. Remember, veins are more often than not, veins can be managed conservatively, but arterial injuries are unforgiving, and arterial injuries, especially major arterial injuries, can cause either death to the patient or death of a limb. As I said earlier, time is of paramount importance. Time, it's always going to be a race against the clock. So therefore, if there's a suspected arterial injury, you need to act then and there immediately. You can't go home and have your dinner and come. You can't keep the patient and say, I'll observe and come and see tomorrow morning. No, it needs to be attended to immediately, because every single minute, every single second counts if it is arterial injury. Diagnosis is primarily clinical. As I said, it's a primarily clinical diagnosis. There is no blood test or scan to diagnose. So your clinical diagnosis of absent pulses, pulsatile bleeding, expanding hematoma, those hard signs that we talked about, that becomes very important. Specialized referral needs to be done whenever there is an identified vascular injury. Specialized referral to a place where there is a vascular surgeon or general surgeon who can repair it. Finally, overall management depends on a multidisciplinary approach of vascular surgeons, general surgeons, radiologists, physiotherapists, and lots of other specialties getting involved. Right, so that's about vascular trauma. Any questions? Any questions? Hello? Hello?
They can unmute and ask their questions.
Yeah, is anyone asking questions? I can't hear any of them speaking. Anyone wants to ask any questions, please go ahead. No questions?
Seems like no questions. We can.
Sorry? Hello?
Seems like no questions, so we can continue.
Right. So if there are no question, we can go into the next one.
Yes.
Okay, let me just get this. I shared the screen. Is it okay? Can you see? Can you see?
Coming up, sir. Yes, we can see now. Yeah.
I'm gonna run the slides a bit. Just tell me if everything's okay.
Okay, sir.
Yeah. Okay. So the second topic is about diabetic foot disease. Okay, I'm going to keep it again fairly short and sweet. Again, just like vascular trauma, diabetic foot disease is a very, very common condition that you come across in your day-to-day practice as interns. Actually, very important, even more than your seniors or consultants, because you all are the ones who first will meet these patients. Your first contact when the patient comes to hospital, it will be you. And what you identify, what you diagnose, and what you present to your seniors, that might actually decide, or that might actually determine the actual fate of the patient as far as diabetic foot is concerned. So just to give you a backdrop of what diabetic foot disease and what the disease burden is, obviously, these are statistics from about 4 or 5 years ago, but still, population in Sri Lanka, if you take 22 million, 10% of them are diabetic. So that's about 2.2 million people in Sri Lanka who are diabetic. And 2% of that will have foot ulcers every year. So we're talking about approximately 40,000 foot ulcers per year. And it is calculated that we have more than 100,000 foot ulcers at any given time. So that's the magnitude of the disease process or disease burden. There's so much of diabetic foot disease because diabetes is an epidemic. Lots of people are diabetic now, and more often than not, people who come to our clinics, they are diabetic, and whenever they have a wound in their foot, that's basically a trigger for limb loss in the future, which means if there is a diabetic patient and a wound in their foot, if you don't catch it early and do remedial measures, there is a very high chance that that patient will end up with a major amputation in the next 1 to 2 years. Why do they get these ulcers? Well, wounds, Well, it's very complex. So I don't want to bore you with a lot of technical detail, but just to tell you, all of us know that diabetic patients, because of diabetes, they have high risk of infection. That everyone knows. Even the common man knows that. But what they don't understand is that diabetic patients are also more prone to get wounds, not just infection, more prone to get wounds. Why? Several things. One, they have a lot of neuropathy, and this neuropathy affects all the nerves in the foot, the motor nerves, sensory nerves, and the autonomic nerves. So starting from below, what is the problem with autonomic nerves? Autonomic nerves, the sympathetic system, that's the one that leads to your usual temperature regulation in the skin, the sweat secretion, all that. So when the autonomic neuropathy is gone, your sweat secretion, your temperature regulation is gone, which means you have dry skin, cracked skin, which is prone to injury. Sensory neuropathy. When the sensory nerves are gone, you have the lack of sensation. So in you and I, in majority of us, our main protective mechanism in our feet is the sensation. So if we go close to a surface which is hot, we feel the warmth and we immediately pull out our foot. If there's the smallest injury, there will be pain. Therefore, we take care not to put pressure on that. We take care of it. That is due to the pain. But imagine if this pain was not there, if we don't feel anything, then we are unaware. So we may be walking with a wound, and the wound gets traumatized repeatedly with each step we take. Each step that we walk, the wound is more traumatized, but we don't know because we don't have pain. We have no idea. So we can walk from here to, say, another 2 kilometers you can walk with a diabetic foot and a wound without any pain, because they have lack of pain sensation. And that is very dangerous because the natural defense mechanism is gone. The natural defense mechanism and the sensory reflex is gone. Therefore, when you get a wound, the wound keeps getting worse and worse and worse. It aggravates because the patient has lack of awareness. Third thing is the motor neuropathy. So the neuropathy affecting the motor nerves. When the motor nerves in the foot is affected, little changes in the foot structure happens. I will show you some pictures how this happens. So when the motor nerves are affected, the muscles, the small muscles in the foot, they get contracted, they get wasted, and that leads to different deformities in the foot, which make it more prone to infection and more prone to trauma. So remember, people always talk about diabetic patients getting more infection, but more than that, before the infection sets in, diabetic patients are more prone to injury. Why? Because of these three things I told you, mainly the neuropathy affecting your motor nerves, causing deformities, affecting your sensory nerves, causing lack of sensation and awareness, and thirdly, damage to the autonomic nerves, which causes reduced sweating and reduced temperature regulation, leading to dry skin and infection. So those neuropathic features, neuropathic components leads to lots of injuries where diabetic patients are more prone to get foot wounds and foot ulcers compared to other people. So these are some of the pictures, right? And on the right, if you see, the right picture is a typical neuropathic wound, right? That is over the second toe metatarsal head. Right? Patient has a big wound, completely unaware, keeps walking on it. Why? Because lack of sensation. So they don't even know. They don't even know there is a wound because there is no pain. They can't see the undersurface of the foot, so they don't know. Only instant they will know there is a wound is when they stand for a long time, if there is any pus discharge on the floor, and then they are wondering how the hell did this water, or how the hell did this floor get wet, then they are looking at the foot and saying, there is a wound there. Other than that, they don't know. So that kind of background these patients come from. If you look at the wound in the left side, you can see it's a wound which looks very dirty. The edges are black. That's called an ischemic wound. Remember, diabetes is itself a risk factor for atherosclerosis. And when there is atherosclerosis, there is lack of blood flow. So it's not just the neuropathy causing more injuries and more prone to getting injuries. Complicating that is the fact that majority of these patients also have ischemia, lack of blood flow. So when there is lack of blood flow, nothing heals. So now you have a problem which is two-pronged, actually three-pronged. First is you're diabetic. Number two, you have neuropathy, which means you're more prone to getting injuries. Thirdly, the injured wound never heals because there's no blood coming. So when there's no blood coming, whatever antibiotic you give, orally or IV, it never reaches the wound area. Whatever things that you eat, that protein never reaches the wound to heal and granulate. Whatever oxygen you take by breathing, that oxygen is not carried to the wound for granulation. So the wound becomes ischemic and dies. When you get these patients, always look for osteomyelitis. Check and look for it. Now you can see, especially in this left foot wound, you can see this. If you look at the foot, it's such a small wound. You don't even think, you don't even imagine. Such a small wound, like a couple of pinheads. It's very small, not even 1 centimeter. You don't think about osteomyelitis in this. You think, it's a small wound. Put it like this will heal. You give some antibiotic, it will heal. That's what you think. But take an X-ray, you can see the corresponding fourth metatarsal bone. There is an internal fracture due to osteomyelitis. Okay? So this is what happens with diabetic patients. As I said, they are unaware. Small wounds, they keep walking. Now, if you and I get this small wound because of the pain, we don't put weight on it. We don't put pressure on it. We go seek medical advice immediately and we get it treated and we get it healed. But diabetic patients lack that sensation, lack that awareness, lack that pain. So therefore, they keep walking, they put pressure on it, and due to repeated pressure, the infection spreads to the bone and bone gets affected, causing osteomyelitis. So that kind of situation, that affected bone segment entirely needs to be taken out and treated. So even though it's a small wound from outside, a massive operation needs to be done to save this foot. This diagram also shows how diabetic foot wounds progress. As I said earlier, you only get initially just dry skin, starts with a small wound, and because of lack of sensation, lack of blood supply, it just penetrates and goes to grade 2, grade 3, forming deep ulcers, abscess, osteitis. Osteitis means osteomyelitis. That's the picture I showed you earlier in grade 3. And later on, there is gangrene. Gangrene means the infection causes sepsis and the muscle death and small muscle death and the death of the toes. And finally, you get a completely gangrenous foot, which is unsalvageable and needs amputation. So the importance of this picture is, imagine if you catch this patient in grade 0 or grade 1, like this patient in the left half of the wound, left half of the picture. If you catch it at that stage, early stage, right, before the infection sets in, before gangrene, now this patient obviously has osteomyelitis, but still, if you catch it early, even with a small wound, and then you do remedial measures, you can save this foot. Compared to the patient going home with that small wound, you forget to take an X-ray, you say, all right, okay, small wound, take a small antibiotic, this will heal. Patient goes home, comes back to you in 2 weeks' time with grade 5 gangrenous foot. So that's the danger of this. So that's why it's very important and paramount that at your stage, you need to catch these patients, even the smallest wound, you need to take care, investigate, look for it, and then do remedial measures. And as I said, diabetes itself is a risk factor for atherosclerosis and lack of blood flow. So therefore, you need to always check pulses. There is no compromise, no alternative for not checking pulse. I can't stress that to you enough. As house services, I have told all my trainees and everyone that I come across, regardless of what you do in the foot, always check the pulse. If you are not used to it, start checking pulses in all patients. You have to know, as a doctor, you need to know, and you have to know how to feel the dorsalis pedis and the posterior tibial pulse. There is no excuse for not checking pulse and missing a gangrenous foot or missing an ischemic limb. So this is how we check pulses, right? The bottom picture, you can forget about it. That is what is something called ABPI. You don't need to do that in the routine setting, but checking your posterior tibial and dorsal pedis pulse, you need to know how to check it. You need to know how a normal posterior tibial and dorsal pedis pulse feels like. And remember, you get very often wounds like this. If you look at the left side wound, left side picture, again, a very small wound, a very small wound. But if you don't do pressure, if you don't compress, you won't see that pus, right? So the important things to identify is that there's a term in English called what you see is the tip of the iceberg, which means what you see from outside is not necessarily an indicative of the depth of the illness. So what you see is only the tip. You can't say, the tip looks fine and then forget about it. You need to examine the pulses, you need to press, you need to compress. Remember, these are neuropathic patients. They don't have pain, they don't shout, they know nothing to do with pain. So you examine properly, press, and then you see the pus, as in the second picture that you get, right? Now imagine this kind of patient, if you just send home an antibiotic, it will never heal. It will form an abscess, and the abscess will track along the tendons, and the patient will very likely end up with an amputation. So this kind of thing, if you check properly, even if you identify the pus, you need to get the patients admitted, take a culture from the pus, clean it up, prepare that patient for a debridement, drainage of the pus, and that's the only way you can save that wound. Earlier, I said about motor neuropathy with diabetes and the deformities you get. And this picture shows some of these deformities, right? I told you how with the motor nerves getting affected, the muscles get wasted, muscles get contracted, and the deformities happen. You can see the deformities. Now, especially the picture at the bottom, you might think that looks normal in an older person. You might think, that's normal in a 70-year-old or 60-year-old Archie or Sia. No, it's not. You can see all 5 toes are clawed. All 5 toes. You can see how the metatarsals have or the phalanges have contracted and the toes are clawed, and that leads to fracturing, that leads to ulceration in the top of the toes as well as the bottom of the toes. It's another thing called Charcot foot. Again, very common among diabetics, where apart from the toes getting clawed and getting deformities, you have a deformity where the midfoot collapses. Midfoot of the foot area, the bones collapse. And you can see the picture on the right side, the real life picture. You have what is called a rocker bottom type of foot. Right? So the normal foot arch is lost. So therefore, when the patient walks, pressure comes not in the heel, pressure comes in the midfoot area, which is not designed to bear weight. And that leads to ulceration. Then there are patients who come with callus. Callus means just dry skin. Right? In Singaling, we call it galthalum, right? Galthalma is a callus. Callus is due to repeated repetitive friction injury, right? And you can say, right, there is a scab that looks healthy and go home, you'll be okay. No, it's not going to be okay, because a callus means underlying there is infection, underlying there's a big cavity, underlying there is a ulcer that is going to form an abscess. Right? So if there is a callus like this lady that where the picture is showing, you need to clean it up. You need to shave it. So callosity, hard skin occurs at pressure points. As I said, it's due to repetitive trauma and weight bearing. Especially in Sri Lankan setting, it is due to barefoot walking. You need to check the pulses. Initially, as I said, you need to get an X-ray, exclude osteomyelitis. Then you have to shave off that callus, like that picture, the bottom picture. And there's something called offloading. What is offloading? Offloading means, I kept saying, most of these ulcers are due to neuropathy and repetitive trauma. That means, to put it very bluntly, a diabetic person who's been having diabetes for, say, 15, 20 years, their nerves, their sensory nerves are lost. Their sensory nerves are non-functional. So they have sensory neuropathy in the foot. The foot is numb. They don't feel anything. So when they don't feel anything, when they get a wound, they don't have pain. That means they walk. So they might come to your OPD, they might come to your ward, you give them diabetic medicine and you tell them, okay, there's a wound, pulses are good, don't worry about it, take this antibiotic, you'll be okay. You ask them to go home. How are they going to go home? By walking. Even to get the bus or a three-wheeler, they have to walk. When they walk, what happens? If the wound is in the foot and the plantar surface, obviously they walk, putting pressure on that wound. Now, if you get a wound like that, will you walk? No. You will hobble around. You will put pressure on the other foot. You'll use a crutch, or you'll use another method of mobilizing without putting weight on it. Or you'll at least walk with the heel so that the pressure doesn't fall onto the wound area. Why? Because if the wound touches the floor and weight is transferred to the wound, you get pain. So therefore, automatically, you avoid putting weight on it. But these patients lack that sensation, lack the pain. So therefore, when they walk, they are blissfully unaware. They just keep walking. They will walk home completely, 2 or 3 kilometers. Sometimes they walk without knowing anything, any damage has happened to the wound. But regardless of you giving the best antibiotic and the best advice, if they keep walking on it, then the wound gets worse. So that's where offloading comes in. Offloading means you take the load of the weight, body weight, off the area of the wound, right? Simple things like this. And now you can see in this patient, this is actually the second toe. The first toe has been amputated due to a previous injury. Second toe tip, you can see again the deformity. The second toe is not straight, it's crooked, it's curved, right? That's due to muscle deformity, small muscle deformities, subtle deformities causing almost like a claw toe. And therefore, when they walk, the tip of the toe touches the ground, and that's why they get an ulcer. So no point in putting a nice dressing on that wound and asking them to walk. The more they walk, that wound will touch the ground and get worse. So simple thing like offloading here, where you plan it out and put pressure proximal to that. So you put a gauze bandage or something, plaster it, so that when they walk, the wound area is now in the air. It never now touches the ground, and therefore you're allowing the wound a chance to heal. These are some other techniques of offloading. You can see the top right-hand corner picture. A wound has healed, a wound which is there in the heel, right? Now, if you just send that patient home without any advice, they will walk on that heel, and the pressure on the heel will cause the wound to open up again. So you give them a special shoe, right, where the heel has been modified. So when they walk, the pressure is now on the front part, and the distal, the heel area, there is no pressure on the foot. That means the wound can stay healed without opening up again. Then I also told you about diabetic wounds. Sometimes, or most of the time, they're prone to ischemia because lack of blood flow. As I said, diabetes is a risk factor for atherosclerosis, so blood flow gets affected. And if you don't feel pulses, then the limb is ischemic. The wounds are ischemic. Then you need to do something remedial like a bypass or an angioplasty to restore the blood flow in order for these wounds to heal. So there are lots of things we can do just for your completeness. These are angioplasty. You can see the rightmost, the right corner picture with the red arrows showing an angioplastic blood vessel. The second picture showing that posterior tibial artery is not seen, but in the right-hand corner picture after an angioplasty, the angiogram shows the posterior tibial artery completely opened up, and blood is now flowing to the wound, which means that the wound will now get more oxygen, more protein from your digestion. All the antibiotics you get intravenous will go to the wound. Now you have a better chance of healing. You can sometimes even do bypasses going up to the foot itself. As vascular surgeons, we do bypasses. We can do bypasses to the posterior tibial, dorsal pedis artery, and we can restore the blood flow. So that again, we are giving the chance for a wound to heal. These are some pictures of bypasses we do. So in summary, diabetic foot disease is extremely common. As I said, over 2 million Sri Lankan people are diabetic, and about 2 to 5% of them have diabetic foot disease, foot ulcers, foot wounds, lots of wounds out there, and lots of diabetic patients. So you can have these wounds as ulcers, proper wounds, black toes, deformities, lots of things can present to you. You need to examine the foot thoroughly. Remember that. The patient may come to you just for diabetes. The patient may come for something else. But if the patient is diabetic, as a primary doctor who sees that patient, unless you check that patient's feet, check the pulses, check for existing wounds, check for neuropathy, and give them proper remedial advice, then the next time they come to the clinic, they would come ready for an amputation. Always check the pulses, right? Deformities, callus is the thick skin I told. I have underlined and put it in bold. You need to be able to check pulse. Please learn and get experience in checking dorsalis pedis and posterior pulse. I can guarantee you, you will be saving a lot of limbs. You need to take pus swabs or culture, take X-rays to exclude osteomyelitis. You obviously need to do blood sugar control, and you give antibiotics according to culture. You don't just randomly give a big antibiotics. You take the pus swab culture and then give empirical antibiotics after that and change according to the cultures. And you do debridement. Debridement means you wound cleaning, surgical cleaning after assessing pulses. And vascular referral is done only if the pulses are diminished or absent. So diabetes threatens both life and limb. If you are careful, we can save both life and limb. Okay, that's it. Any questions?
So if you're all having any questions, please unmute and ask, or you can use the chat box.
Yeah, I can hear somebody's voice. Go ahead and ask. Hello. Does anyone have a question?
So could you share the slides with us, please, if you don't mind?
Yes, I will. I don't know how exactly to share with all of you. I will send it to the college and ask them to share with you. Yeah.
Yeah, sure. Thank you.
Anything else? No questions. Good news. So you all are experts in diabetic foot and vascular trauma. Happy. Okay, can I ask you all a question? How many of you are confident in checking dorsalis pedis and posterior pulse? Yes. Just unmute and say yes or no. That's all.
Yes, sir.
Good. So only him, only Shaki. So James Vijay Naik has sent a direct message saying, can you explain about Charcot's foot? So Charcot's foot, as I said earlier, is due to mid-foot collapse. So that means, so with chronic diabetes, when your diabetes has been going on for years and years and years, generally this happens with diabetic patients after 10, 15, 20 years. When diabetes has been in your body, as I said, lots of changes happen. The diabetes itself causes destruction of your nerves, It then causes motor neuropathy, sensory neuropathy, and autonomic neuropathy, and lots of changes happen. These changes result in sometimes the weakening of the bone and the weakening of the muscles and tendons that give structure to the bone and the medial plantar arch. So when these tendons that maintain the medial plantar arch are damaged due to the muscle neuropathy, motor neuropathy, and then the bones get weaker, there's what is called midfoot collapse. So the midfoot of the foot, basically it collapses like a bridge collapsing. Imagine a bridge collapsing right in the middle. There's a bridge going over a river and the bridge collapses in the middle. It's something like that. So the midfoot collapses. Right? You remember that picture I showed you? Where is it? Yeah, this one. I'm showing to you the picture again. Do you see this? Do you all see this picture?
Not yet, sir.
Okay, hold on. I seem to have lost it. Hold on. Share the screen again. No? Sharing the screen again. Can you see now? Can you see now?
Yes, I can see. Yes.
Yeah, so now this is the picture, right? The midfoot collapse. You can see in the drawn diagram in the left where the healthy foot shows that medial plantar arch, right? The skeleton is normal. But whereas in a chronic diabetic patient, the midfoot, which connects the hind foot to the frontal part of the foot, midfoot is broken down, collapsing, right? It's a painless condition. Remember, not like a fracture, which is painful. These patients, this is not something that happens overnight. No, this is something that happens due to weakening of the bone and weakening of the tendon structure over a matter of 10-15 years. So gradually, little by little, it collapses. And patient is not even aware because it has happened over such a long time. They think, this is my normal foot. Because if something changes happened over 10-15 years, it's very, very subtle change. So they don't know. They think, my foot has always been like this. No, it's due to midfoot collapse. So the midfoot, like a bridge collapsing, it has collapsed. And therefore, when it collapses, now when they're walking, the pressure is not on the heel and the metatarsal head. Now the pressure is on the midfoot because that's the most dependent part of the foot. And that leads to severe ulceration. So that's called Charcot foot. Okay. Any other questions? Only one person was confident about checking pulse. Out of 300 participants, 320. That means one person is confident, 319 not confident about checking pulse. Okay, any other questions?
Yes, sir. One question on the chat box.
If there is a callus formation apart from checking pulses, taking X-rays and repeated shaving, what are the interventions we can carry out? Yeah. So if there's repeated callus formation, as I said, very simple. Why does the callus form? Due to repetitive trauma. Why is there repetitive trauma? Because they're walking on that wound. Very simple, right? So whatever X-rays you do, whatever you take, whatever shaving you do is not going to heal the wound unless you give advice about offloading, which is what I told you about offloading. Offloading means once you shave that ulcer, once you shave that the callus, you need to explain to the patient, look, man, You are getting this wound again and again and again, not because I'm a bad surgeon in shaving, because I have done inadequate shaving. It's because you keep walking on it. The more you walk, you put pressure on that wound, and therefore the repetitive trauma will cause this to have another callus after 2-3 months. So therefore, you need to explain to them about offloading, which is the pictures I showed you about those special footwear. So you need to take them or advise them, go to a place where they can make a special shoe for you. Majority of the teaching hospitals now have special rehabilitation units, orthopedic units, which have special rehabilitation units where they make prosthetic shoes, special shoes, so they can identify the pressure points, pressure areas, pad those areas, offload them, and make specialized shoes so that that area does not carry pressure. And then once you shave the foot or shave the callus and ask them to wear this shoe, if they are compliant, then yes, the ulcer will, the callus will never form again. So very simple thing. Okay. So the most important thing in management of callus, not shaving the callus. Shaving the callus is like, dyeing your hair. You just do a temporary thing. It will always come back unless you prevent repeated trauma on that. How do you prevent repeated trauma? You need to prevent walking, putting pressure on that. So you can't ask a patient not to walk. No, people have to walk. People have to go to the toilet. They have to go to work. They have to go to various things. People have to walk. Anyone can say everything about don't walk. I mean, that's rubbish. That will never work. People can't just stay in bed 24 hours. So you need to tell them you can walk, provided you wear this shoe, proper offloading shoe. So with proper offloading shoes, people can go to work, they can get about their normal activities, and the callus will not form again. So it's a very simple thing. So the most important thing in management of callus is actually not the shaving part. It's about identifying pressure areas, advising them about it, telling them to get the proper diabetic shoe or offloading shoe, and making sure that they wear that shoe. That's the most important part. Any other questions? Sorry, there were 2 questions earlier. Now I can't find the second one. What was the second question? You can unmute and ask. Huh? Yes. Don't get scared. Just ask.
Yes, sir. Yeah, they can unmute all.
Someone is asking, sir, in acute limb ischemia, what are the instances when we give heparin thrombolytics or doing a thrombectomy? So now this is nothing to do with diabetic foot or vascular trauma. Do you want me to answer this question or what? You're asking about acute limb ischemia, which is not pertaining to the 2 topics I talked about. If you really want an answer to that, I can give you an answer now, or I can send the answer to you separately, but that's not relevant to this particular talk.
We can answer now, so if you prefer.
Okay, so acute limb ischemia is a separate condition where people get thrombus or an embolus blocking the blood vessels and causing lack of blood flow, resulting in loss. If you identify it early enough, the patient comes, you can do a thrombectomy or an embolectomy and save that leg. 100% of the time, these patients need heparin. 100% of the time. All of them need heparin unless there's a contraindication. What are the contraindications? Obviously, if the patient is also having a coexistent intracerebral hemorrhage or something, or if the patient is unstable, then yes, then you can't give heparin. But majority of the time, these patients are simply having only the limb symptoms and not anything else. So therefore, heparin can be given, and heparin has to be given 100% of the time. You give a loading dose of 5,000 units heparin IV, followed by an infusion of 1,000 units per hour, and then titrate it with APTT control, having a target APTT of 80 to 120. That's standard treatment. Thrombolysis is a different thing. Thrombolysis means not heparin. Heparin is anticoagulant. Remember 2 different things. Heparin and warfarin are anticoagulants. Thrombolytics are different types of drugs. Heparin and warfarin are anticoagulants which will prevent the existing thrombus from propagating, anticoagulant, preventing further clotting. Thrombolytics are the ones that actually dissolve the existing clot. Thrombolysis, thrombolytics. Thrombolytics are streptokinase, urokinase, tissue plasminogen activator, TPA, TPA products like tenecteplase. There are different things that you use. The common thing you are aware of is obviously streptokinase and tenecteplase, which people use for myocardial infarction. So similarly, if an otherwise fit and healthy person gets an acute limb ischemia and presents to you within the first 2 weeks of onset, and if the limb is still viable, then there is a place for thrombolysis of that patient. So that can be done. But that has to be done in a control setting. It's called catheter-directed thrombolysis. You can't just give IV. You need to place an endovascular catheter to where the clot is, then start an infusion of thrombolytics, and then control that thrombolysis rate in order to prevent the thrombus from clotting, thrombus from breaking off and causing further complications. Remember, when you give thrombolytics, right? Now it's a separate topic. So if I start talking about it, I can go on. So I'll just give you one sentence. So thrombolytics is good, it is effective, but two things. One thing is thrombolytics, when you give, there are ischemic complications. You can have hemorrhage, intracerebral hemorrhage, you can have perforated peptic ulcer, lots of things can happen. So that's why you need to find a good fit patient who can withstand it. Second thing is, when you give thrombolytics, when you insert or when you inject thrombolytic drugs, streptokinase, urokinase, TPA, tissue plasminogen activator into a thrombus, you have no control of the how the thrombus is getting dissolved. So it's like putting a bomb somewhere. And once you put a bomb somewhere, you don't have any control of the pieces that flow around. Right? So it's not like a thrombectomy or embolectomy where you remove the entire clot. No, you're using a thrombolytic agent, an infusion, where only now this thrombus is breaking off pieces and destroying the thrombus. So these broken pieces, you have no control where they go. So then they can cause havoc by flowing distally and causing further aggravation of symptoms. So there are thrombolysis is not trouble-free and it's not a magical thing. That's why people don't do it all the time. So there is a definite limited place for thrombolytics in selected patients. Okay, that's all. Anyway, like I said earlier, that's a completely different topic, not pertaining to what we talked about today. So don't get confused. I said that only as in response to a question that was asked. Anything else? Okay. Done. Finished.
Yes, sir. If there are no any more questions regarding today's topic, we can conclude, sir.
Okay, no? All right, so we'll conclude then. You all wanted the slides. I will send it by email to someone. If one of you can send me an email to my my address. In response, I will reply with those presentations. Okay.
The plus the whole broadcast, it's broadcasting live on the YouTube, so they can go on the YouTube and watch also.
Ah, right. So then it's easy. Then I don't even need to share slides. But anyway, if someone wants, you send me a message, I'll send it to you. Right? All right, guys and girls, all the best. Thanks for asking me to talk about this. I hope you all become very good interns and very good doctors in the future. All the best. Okay. Bye.
Right. Thank you very much, sir. That was Dr. Nala Gunawansa, consultant vascular surgeon from National Hospital, Colombo, for giving that comprehensive lecture on diabetic foot and vascular issues. Thank you, sir, once again. So we thank College of Surgeons for organizing this program along with Minister of Health. So we thank Dr. Diane Ekanaka, coordinator for this program, consultant plastic surgeon from National Hospital, Colombo. So that concludes today's program. We will share a link. Please submit that feedback. It will be taken up as the attendance. Plus tomorrow, quality and safety lecture series, another important one. First time we are doing. So make sure that you are logging by 8:45. Right. Thank you.